All right, hello everyone. Has everyone got their translation? Est-ce que vous avez tous vos appareils d'interprétation? Voilà, merci. It's going to be English mostly for the start, but then we're going to have a bit of French. Okay, so thank you very much. Welcome everybody to Château de Pont, and well done for getting here despite all the buses and the holidays. So welcome to this Health Data Collaboration 2-day workshop on better data for better health, investing in country health information systems to accelerate progress towards the SDGs. So my name is Samantha Bolton, and I'm going to be moderating the session. I started off as a journalist at the BBC and Reuters, and then I worked for Médecins Sans Frontières and WHO, mostly in emergencies. And then I guess you may have heard of the 10-90 gap, which is, 10% of the world's resources were spent on, research resources were spent on diseases that affect 90% of the world. So that one number, 10-90, stimulated the creation of all these public-private partnerships, to find new treatments for medicines and diagnostics. I also worked for those, a lot of it with Gates money. But all this to say that numbers and data are key, and they can make or break a program. They can help stimulate good campaigns, create organizations, and move for change. But as we all know, data, we're inundated with data, and a lot of it's quite useless or excess, but it takes a lot of time and money for the people on the ground, especially for the nurses, the community health workers. And so what we're all here to do is to work out what is the essential data that we need and how can we fund it and how can we make it work so that it works really for the needs of patients and health in country, for the primary healthcare, universal health coverage and the SDGs. We're also here today to follow up on the recommendations which came out of the 2021 Data Governance Summit. So we have a lot to do and a lot to go through. So please keep your interventions and your comments concise and to the point, but we want to keep it lively because there's a lot of presentations to go through, including high-level representation from countries, which we're very welcome to have. And we are here especially to listen to what the countries need and what they're advising, especially also from the partners, the multilaterals. So hopefully it's going to be a good exchange. Another thing, we're here in beautiful Switzerland. It's slightly colder than normal. And as you know, it's the country of mountains, clocks, good timekeeping, and beautiful cows in the mountains. So if you start to go over time, let me take this out. Good start. Okay. If you really go over time, all right. So that's how we're going to keep time with everyone. So without further ado, we're going to move to the officially start, and we have a welcome on behalf of the countries from the Minister of Health and Wellness of Botswana, Honorable Edwin Dikoloti, and he's online. So let's welcome to. Thank you.
The Health Data Collaborative aims to empower countries and communities so they can ensure healthy lives for everyone. We do this by 1. Strengthening country health information systems. 2. Aligning partner support for country priorities. And 3. Adapting global tools to local contexts. There are many people around the world whose lives aren't officially recorded. People in these left-behind communities are often stigmatized and discriminated against, and counting them can be difficult because of their quasi-legal status.
If you have a section or a sector of the population which are invisible, then you're already having inequality to start with.
The longer this situation continues, the more people will suffer.
Partnerships such as the Health Data Collaborative are crucial. Partnerships like this help countries provide quality foundational data in a better way, which then again improves healthcare quality and health system performance.
We are made up of 7 constituencies: countries, multilateral and intergovernmental organizations, donors, global health initiatives, academia and technical networks, civil society organizations, and the private sector. The power of this public-private partnership gives all of our members 4 key advantages. 1, aligning to common goals, whether that be the Sustainable Development Goals, universal health coverage, or national goals. 2, access to a diversity of approaches and ways of looking at problems that lead to better and more appropriate sustainable solutions. 3, technical and financial resources that can be invested more efficiently because they are centered around common goals. And 4, decreased fragmentation of reporting and collecting, reducing the reporting burden for countries and frontline health workers. HDC partners can support the best practices of different elements along the journey, including collection, storage, security, sharing, analysis, validation, and visualization. The resulting data helps to plan better health budgets, improves responses to diseases, and saves lives.
We collect this data every day, every week, and every month. We analyze the data, and then we ensure to know which kind of clients we have. We are able to understand where to take our services to.
If we didn't have this data, we wouldn't know what we are doing. We wouldn't know who we are serving. We wouldn't be able to plan.
But collecting health data can, in itself, become a burden.
The issue is that there's so much duplication around what's going on around the world. If we have 190 countries doing 190 things, it's just going to get complicated. Even within individual countries, there are many, many data systems.
The HDC partnership helps to harmonise data collection methods, easing the administrative burden on countries. The HDC have also established networks of working groups to address specific technical issues and identify and fill technical gaps. COVID-19 has underscored the importance of strong data governance for building trust and transparency around data sharing. And while the pandemic has provided a vital new focus on data in the short term, in the longer term, the HDC is focused on the SDG 2030 agenda and goals, many of which are about equity and sustainable institution building.
The SDG agenda, the whole idea is to leave no one behind. So CRVS systems is about counting everyone, because everyone counts.
Thank you, Director of Ceremonies, Dr. Samira Asma, Assistant Director General, Data Analytics and Delivery for Impact at the WHO, honorable ministers here present, co-hosting partners, Health Data Collaborative Secretariat, distinguished ladies and gentlemen. It is with great pleasure and honor that I welcome you to this event on behalf of the HDC Impact Countries hosted by the Health Data Collaborative and its partners under the theme, Better Data for Better Health, investing in country health information systems to accelerate progress towards health-related SDGs. About the HDC, since its inception in 2016, the Health Data Collaborative has demonstrated measurable impact in several countries, many of which are represented here today. The HDC has 3 specific objectives. 1, health information system strengthening. 2, alignment of resources. And lastly, adapting global goods to local context. Director of Ceremonies, the Ministry of Health of Botswana launched its own Botswana Health Data Collaborative in March 2020, with a mandate to rally all actors in the space of health information systems and monitoring and evaluation towards a common monitoring and evaluation system to achieve efficiency, transparency, accountability, and ultimately lead to a better and improved health system. This followed an assessment of health information and monitoring and evaluation system in 2018, which highlighted the fact that partnerships in HIS and MNE are generally poorly functional and in some cases non-existent. Before the inception of the Botswana HDC, there was no multi-sectoral platform for monitoring and evaluation. Partnerships and engagement with the private sector and civil society was limited and on ad hoc basis, and there didn't exist a framework for this engagement. Distinguished ladies and gentlemen, the operational plan formulated was based on BHDC broad strategic priorities, which include: 1, improving data and information use for informed decision-making. 2, leveraging on digital technology. 3, improving civil registration and vital statistics. And 4, improving quality and safety of care. To date, the Botswana HDC boasts amongst its achievements establishment of national technical working groups on digital health, data and information use, civil registration and vital statistics and quality health care, implementation of a unified national e-health architecture, harmonization of data collection and reporting tools in line with the National Indicator Reference Manual, development of the National CRVS Strategic Plan, that of 2021 to 2026, an introduction to ICD, mortality, mobility reviews, and clinical audit. We encourage more countries to follow suit and subscribe to the tenets of the HDC after this event. And on accelerating progress towards the SDGs, we acknowledge that the world is behind in meeting the UN SDG targets. Nonetheless, achievements made must and should still be recognized. In 2021, Botswana was acknowledged for bringing the mother-to-child HIV transmission rate to under 5%, providing antenatal care and antiretroviral treatment to more than 90% of the pregnant women, and achieving an HIV case rate of fewer than 500 per 100,000 live births. The probability of dying from non-communicable disease in the country has also decreased since 2016. And gender equality in education is almost at 100%, 97.9% to be exact. The global health data gap remains a major barrier to the achievement of the SDGs. Without data on what works, what improves populations' health and well-being, and how to reach undeserved and marginalized populations, it is impossible to achieve these goals. Director of Ceremonies, ladies and gentlemen, through good governance and investment in quality and actionable health data, we can improve the way we measure progress and in turn accelerate progress. And the power of partnership and call to action, allow me to thank partners of the government of Botswana, including the multilateral organizations, the donor organizations, global health initiatives, the private sector, research and academia, as well as civil society, for the role that they have played in building our national health information systems. I take this opportunity to call on partners to improve coordination, reduce multiplication of reporting tools, and prioritize alignment with government plan and strategies, not just in Botswana, but also in countries across the globe. In this vein, it is my belief that this event will lead to actionable outcomes and will trigger improvement of stakeholder alignment with the national priorities. Director of Ceremonies, ladies and gentlemen, once again, I'm extremely pleased to welcome you to this event with its timely and important theme, investing in country health information systems to accelerate progress towards health-related SDGs. I wish you fruitful deliberations and challenge you to leverage the power of partnership and use the Health Data Collaborative as a platform to come together as stakeholders in health data to achieve better data for better health. I thank you all.
Thank you, Minister. Now, welcome on behalf of the partners. We have Claire Melamed, who's the Chief Executive Officer, Global Partnership for Sustainable Development Data. Thank you. Thank you all. It's a real pleasure for me today to be welcoming you all to this event on Better Data for Better Health. And of course, an honor to share a stage with the Honorable Minister and with Dr. Samira Asma, who is the Assistant Director General of the WHO. This discussion, of course, is happening. 2023 is a critical year for the SDGs, for health, and politically as well. We're at the halfway point for the SDGs. We're looking forward to seeing world leaders commit to accelerating progress at the SDG summit in September. But as we all know, in order for countries, for individuals, for companies to be able to set their own path, make their own choices, determine their own destinies and pathways to accelerating progress on the SDGs, there are two critical things that are needed. One is resources, and there is already, of course, as many of you I'm sure are involved in, a huge political conversation going on about mobilizing resources to accelerate progress on health, on education, and on all of the most critical SDG priorities. But along with resources comes information, comes the information and the data to be able to use resources effectively, to fully appreciate the choices available, and to make sure that countries are able to have the information that they need to make their own choices. So resources and data and information go hand in hand as we think about mobilizing globally to achieve the SDGs and to accelerate progress in this second half of the period. The next few months offer some critical opportunities to do that, particularly in the field of data, where perhaps politically we haven't yet found ways to mobilize as effectively. We're seeing with the Indian presidency of the G20, data on the agenda in a way that we haven't seen it before. We've seen the government of Kenya committed to launching ambitious new data initiatives at the Africa Climate Summit in September. And then, of course, we will be seeing again in September, it's going to be a busy month, the SDG summit, where data, as we saw from the SDG progress report released a few weeks ago, is going to be absolutely front and center of the story. It doesn't need me to remind any of you in the health field that data and health information systems are an absolutely critical public good. That when countries invest in the data, in infrastructure, in the capacities and the governance to exchange and use the data, which comes out of health systems and which is produced as we all go about our business every day, it's then that the economic and the social returns can really be mobilized and can make the difference between SDG achievement and backsliding. In health, as in all sectors, when countries do invest in the foundational data systems, we see the realization of a powerful data dividend. I'm going to be talking a bit more about this tomorrow and give you some numbers, but the headline from the research that we released at the UN General Assembly last year is that for every dollar invested in data systems, the average economic return is $32. This is a great investment by anybody's standards. So I'm delighted to see that the Health Data Collaborative is building on the investment case with an investment case for health information systems specifically, and really looking forward to learning more about that over the course of the discussions here over the next few days. And of course, a lot of this excitement about data and the potential for investing in data and for new insights that used not to be available comes from the fact that we have more data available than ever before in terms of volume, and more opportunities in terms of new technologies to use that data and to get data from different sources to give us a really rounded picture of what is going on in the world and in people's lives. But with those new opportunities, new data sources, of course, also comes new risks. We mustn't get carried away by the technology and forget about the people. The pace of change is sometimes confusing, sometimes bewildering, and certainly takes a while for governments and government policies to adapt. We need new frameworks and new mechanisms to govern data in a way that protects communities and prevents these new systems from perpetuating inequalities if we're really going to realize the promise of data that I think we all recognize is there. And effective data governance, which creates the space for people to shape whether and how their data is used, is also absolutely fundamental to establishing public trust. And as we've seen in many countries, and during the pandemic, when data was at its most critical, if we, in the absence of public trust, often citizens can resist their government's attempts to use data or contact tracing apps, mobile data, and so on. And in that case, we're just wasting the huge opportunities that we know data can provide. Without the foundation of trust, we can't unlock the data dividend. Most governance, of course, needs to happen at the national and the regional level, but there is an important role for global principles and frameworks to establish common norms and expectations. The WHO, as so often in data, has been ahead of the curve in this regard, has hosted the Health Data Governance Summit in 2021 that set out the global data governance framework with good data governance principles. So it's really great to see the discussion continuing here. And I'm really looking forward to hearing about good data governance practices in the discussions on the country level approaches from so many of you that are here today. Too often, I think we have these discussions in parallel tracks. We talk about data governance and the need for investment in data systems in separate conversations, in separate political forums. But investment and good governance must go hand in hand if we're going to realize the benefits of the data dividend. Trustworthy governance frameworks that establish transparency and accountability create the enabling environment for more effective and coordinated investment. It's a real pleasure to welcome you all today, and I'm really looking forward to discussing ways to strengthen both data governance and financing. Thank you.
Thank you, Claire. Okay, so now, sorry, we're running a little bit behind schedule, so we're gonna move straight to Samira Asma, who's gonna make the opening remarks. She's the Assistant Director General from the Division of Data Analytics and Delivery for Impact of WHO. Thank you, Samira.
Guys, the mics, please. Can we make sure that one's working?
This is fine. This is fine. So good morning and very warm welcome. And I would like to also thank the Honorable Minister, who really spoke very eloquently about the need for a coordinated response to country needs and the successes in Botswana. And Claire, thank you for giving a very good opening and valuable insights as to what we can do and what is coming up. And to all in the room, representatives from partner organizations, from governments, and colleagues and friends, I want to thank you for being here and many who are joining us virtually. I also want to thank you and all partners for supporting the Health Data Collaborative. It is an immense resource. It brings in about, I believe, 800 partners or individuals, but about 80 partner organizations, countries, and governments and stakeholders together to discuss the need for better data to drive a measurable impact in countries. So I think the key word is not just better data for better health, but the middle part is driving that measurable impact in countries. This meeting is coming at a very important time. The World Ministers of Health will assemble Sunday onwards in Geneva to discuss and to reflect on the progress, but also the setbacks due to many concentric crises, and to see how we can collectively move outward and forward. Tomorrow, we are releasing the annual publication, the World Health Statistics Report. It is the annual health checkup of the populations globally. And we all expect the news is mixed. It is not very good. It is it's grim. And it's been said many times that we are off track to meet the health-related SDGs or SDGs in general. The crucial component is that health connects with all SDG goals, and there are about 59 health-related SDGs. There are about 194 member states. It shouldn't be such a big challenge to solve the recurring and long-standing data crisis that we all find ourselves in. We all in this room have the resources, the respective organizations we all represent. The failure perhaps often is that we are not listening to the country needs. And what we need now is very tailored solutions for the countries. An initiative that was launched about 5 years ago, the SDG Global Action Plan, that brings in about 14 multilateral organizations together, undertook a review of 46 countries. And there was an assessment as to how multilateral organizations are responding to country needs and country priorities. And again, the response has not been positive. Many of us don't really listen to the country priorities. We are promoting the tools that we are passionate about, that we have developed. And now is the time to collect the tools that we have. We have immense tools out there. But I think all of us are eager to publish more, to develop more. When Dr. Tedros took office in 2018, an assessment was done within the World Health Organization. We had about 11,000 data sets, databases, all fragmented. And this must be a similar case in many organizations. It is a reflection of the fragmented nature of our human condition that I think we ought to overcome. So what we have done is, under the leadership of Dr. Tedros, bring in data analytics and delivery for impact and the science division with the digital health and innovation together as a cross-cutting enabling function throughout the organization to support the universal health coverage programs and primary health care and the underlying programs, to support health emergencies, preparedness and response, as well as to support the programs that deal with determinants of health and how policy solutions can truly be a game changer. And we are making progress, but we can't do it alone. And we would really want to strengthen the partnerships and work today and tomorrow, taking a real focus on countries. I just give you a firsthand example. 2 months ago, Minister of Health from Madagascar was here during the executive board and asked for support from WHO and partners. We met, and his request was HIV incidence is increasing, neglected tropical disease, increase in lymphatic filariasis, and needs support on maternal and to address maternal mortality. We brought our partners and programs together. A group went to Madagascar in a very concerted collaborative way across the 3 levels of the organization. We had our regional offices and the country office representatives. And in the country, all the other partners got together, stakeholders. And now the beauty of this meeting was that the minister wanted support in these areas. We cannot just say we need better data and better health information system in a generic term. It is looking through the lens of the priority that the minister has requested, and then bring the solutions that are data, digital solutions, innovations, and technologies to those areas. While I represent data analytics and delivery for impact work, it can't be done in a vacuum. We have to look through the filter of the various priorities, infectious diseases, non-communicable diseases, the emerging diseases, and climate crisis, and how we can then tailor data and health information systems towards that end. Again, come back to the measurable impact in countries and making an impact in the lives of the people we serve is going to be extremely important. So my few messages for us to work collectively is what truly do countries need and what the partners' resources exist and are available, and how we can then bring that together and knit it together so that we can reduce the incidence of HIV in Madagascar, reduce maternal mortality to see if there are routine health information systems available. We are using digital solutions and technologies. You mentioned the international classification of diseases or geospatial information systems, how we can reduce the gap in inequalities within countries, and also looking at innovations in terms of access to medicines, technologies that can accelerate progress. So I think for us, this 2 days is going to be crucial. As Claire, you mentioned the upcoming high-level meeting followed by the SDG summit and next year Futures Summit. So we have the SDG goals. They are not going away. Countries are committed to meet the SDGs by 2030. The outlook is not very positive, but I think the positive part is that we have the partnerships and the political will in the countries, as we heard from the minister, and many of the representatives from countries' leadership are here today and will join us. So I think we have a tremendous opportunity to, again, listen to the countries, to improve what are we measuring and do that better. For example, the metrics for universal health coverage. Many countries have already said that this is inadequate. It does not address all the essential services that countries need to progress towards. So we will be working with member states and partners to improve the UHC index or UHC measurement that also addresses many other elements like mental health, which is not included, or palliative care, which is necessary and doesn't include in universal health coverage, or rehabilitation. So there is one area that we really need to address is improving the measurements, improving the systems to drive progress and towards better programs and policies in countries. So with that, I want to sincerely thank you on behalf of WHO, and we welcome you here. And on behalf of the Health Data Collaborative, it's an honor for us to serve as its secretariat. Give us the feedback as to how this can become a more better collaboration that can truly be supporting each other, and we advance together. So with that, I pass it back to you, Samantha, and thank you again very much. Look forward to the discussions and dialogues and the outcomes that come forward. I think the data governance agenda is going to be extremely important. So we look forward to see what comes out of that discussion so we can take it forward. Thank you again.
Thank you so much, Samira, especially for coming in person. Thank you. Okay, great. So if we could just ask Steve and Alain to come forward. And Steve, sorry, you can sit here just so that we catch up on some of the time. And now we're going to get setting the scene. We have Alain Labrique, who's the Director, Department of Digital Health and Innovation of WHO. Thank you.
Thank you so much. And thank you, everyone, for this opportunity. Let me start by saying, distinguished guests, excellencies, and dear ADG Samira Asma, it's really a pleasure to be with you here today and to have a chance to speak about some of the exciting breakthroughs that we're seeing in data systems and digital health that we believe are changing the landscape we work in. The future is here. Today in India alone, there are going to be 350,000 telemedicine consults happening digitally. In Rwanda, up to now, there have been 2.9 million teleconsults and e-prescriptions issued. In Bangladesh, 90 million women are enrolled in the open source platform to manage continuity of care. And 90% of pregnant women in Zanzibar are connected through digital health systems. So the world is a very different place than it was 5 years ago. Well before the pandemic, many of us, led by member states, have been advocating for a shift away from discordant proliferation of disconnected vertical pilot projects in digital data capture and service delivery systems towards true national digital transformation, as we heard the Honorable Minister mention earlier this morning, built on solid architectural foundations that drive us towards better, more equitable, person-centered health. This image of the number of disconnected projects across the landscape of the country of Uganda reflected the state of affairs before the famous 2011 moratorium issued by the Ministry of Health to cease and desist new experiments in data collection and digital health systems. It caused a ripple effect through the global digital health ecosystem. It was a wake-up call for us at WHO and for governments everywhere that governments need to be in the driver's seat of digital transformation. And this is a transformation that the pandemic has only accelerated. Over the last decade, WHO has been working to enable this digital transformation, working to strengthen the quality of evidence, the robustness of the science underpinning the field of digital health and data collection, and developing the architectural blueprints needed to enable national scale digital transformation for better data and for the delivery of quality of care for all. From evidence-based guidelines in 2019 to member state ratified global strategy on digital health in 2020, the global ecosystem of informaticians, policymakers, technical experts have been working to develop tools like the Digital Health Investment and Implementation Guide to codify the roadmap for government-led digital transformation. The 4 key objectives of this strategy challenge all of us, as Dr. Asma has just done, to support member states to develop costed appropriate strategies, to bolster the technical, the implementation, the governance, and the legislative and policy guidance required to reduce the reinvention of wheels and the duplicative investments that are driven by vertical systems that have proliferated over the past many decades. Working closely with our colleagues in DDI, we in digital health and innovation and in the science division share the vision of a digitally enabled future where everyone is benefited for a more harmonious, coordinated digital ecosystem, where service delivery, according to evidence-based guidelines, is powered by the same systems that generate the data streams needed to measure and track health progress that Dr. Asma just pointed out. That's the bottom line. We have a growing number of examples of countries that have invested in national interoperability standards and a local enabling environment where a common data model like HL7 Fire enables a sea of point-of-care solutions, facility health record systems, and patient health applications to interconnect thanks to these shared technological profiles. We have a roadmap for this transformation that is centered around data and digital health strategies and investment planning that allows governments to stand up the enterprise architecture that makes this kind of interoperability on the ground possible. What this means is investing in standards-based shared services, shown here on blue on the top, which can be accessed by the ecosystem of entrepreneurs, of local entrepreneurs in country, developing everything from lab information systems and supply chain management tools to national universal health coverage and reimbursement systems, connected through a privacy-protecting interoperability layer shown here in green. This is happening around the world today in high and low resource environments, allowing for investments to go farther, be more sustainable, and preventing governments from being locked into monolithic systems. But instead, fostering, as we have all seen during the pandemic, is something that's absolutely necessary, local capacity to own, adapt, and extend and maintain national public health service delivery and information systems that are standards-based. In the absence of this architectural approach, we're left with many independent digital tools that collect, store, and visualize data. This means we end up creating custom integrations to share data through different systems. One custom integration per software can quickly get very messy. When scaling through these systems, trying to share data with each other, which also has significant long-term maintenance costs, resource, and knowledge costs. This can further be simplified when a standard like HL7 Fire, which is free, versatile, fast, easy to build on, and allows accessibility online and offline, is used to develop the point-of-care service delivery and data collection systems. This year in the US, the Office of the National Coordinator began enforcing penalties for data not presented in an interoperable FHIR-based format. 3 days ago, so I had to update this slide very quickly this morning. 3 days ago, the Africa CDC and the African Union have issued recommendations seen here that FHIR standards be used to collect, exchange, and drive digital health and data systems. The European Union's Interoperate and India's Digital Health Blueprint focus on implementing FHIR-based profiles for personal health records and data sharing across providers. New Zealand's Ministry of Health, the United Kingdom's National Health Services, all provide access to national patient identifiers and data using FHIR systems. In a nutshell, this exciting sea change is seeing a shift from monolithic proprietary systems with little baked-in interoperability, and more importantly, challenging continuity of care across these health verticals, making the patient journey, the experience of the people on the ground, unnecessarily difficult. And interoperability across these systems makes things less expensive and less time-consuming. By shifting to an open, flexible, standards-based model, interoperability is facilitated, but also allows local application developers to focus on delivering quality, usable solutions that delight the end users, delight that community health worker who's being asked to use technology to deliver care on the front lines. But it also meets their workflow needs and the data we need them to capture to better understand the performance of the health system. This merges service delivery and data capture whenever possible. And I apologize, my face is blocking some of the screen there. WHO is leading a process known as the SMART Guidelines process of making all WHO technical and normative digital content digitally accessible. And by that, I don't mean PDFs that you can read online. It's actually able to be ingested by digital systems that are being built in countries, preventing errors from creeping in as technology developers try to translate these thick guidelines into operational on-the-ground service delivery algorithms. So working with technical areas, we're currently focusing on digitizing the entire primary healthcare continuum into digitally ingestible formats. We call these SMART guidelines because they are standards-based, machine-readable, adaptive, requirements-based, and testable for digital transformation. Several key PHC domains, including ANC, or antenatal care. Maybe you can just advance the slide because it's stopped moving. Including antenatal care, have been already digitalized with generic reference softwares having been made available to build upon. I think we've had a little bit of technical difficulties. So while they're catching up, I think we're on slide 17. So there we go. Next one, please. Perfect. And these machine-readable guidelines are growing in number with fantastic buy-in from member states and from technical partners. What these enable us, we believe, to do is to encourage the paradigm of collect once and use many times. And I think that's something everyone in the room is a strong proponent of. It reduces the burden on individuals and it increases the value of the data that's collected at the point of care. Just as an example, over the last 3 years, we worked with engineers at Google Health to develop what's called Open Health Stack, an open, free developer environment to facilitate and empower local ecosystems, local developers in country, especially in low resource settings, to build FHIR standard-based solutions on the ground to deliver WHO SMART guidelines. Open Health Stack components offer a comprehensive set of features that simplify the transition from large-scale monolithic systems to standards-based environments. It enables full offline functionality for mobile app developers, making it easier for them to create robust and user-friendly health applications. Next slide, please. This is a good lesson in technological humility, where you can talk about technology, but if it doesn't work in Geneva, that means it will work in Botswana because you're way ahead of us in terms of architecture. The Android FHIR SDK provides modular libraries for data collection, offline solutions, and clinical decision support, enabling developers to build secure and compliant FHIR native applications very, very quickly. Next slide, please. The SMART guidelines content reduces the time for development while maintaining quality with a standardized data model among local technology developers. This means whether you're building an application for immunization or an application for the delivery of routine maternal and child health care, the data models inherently within the system allow for individuals to move through the system with continuity of care and with that data being interoperably shared across those verticals. Next slide, please. It's been great to see how quickly this has evolved into a real community globally of developer, implementers, and other groups. Next. More importantly, as we race to find ways to bridge the gap in SDG progress caused by the pandemic, building data and service delivery systems faster, better, and locally that are scalable is a priority for all of us. Next slide. WHO is launching the WHO Digital Health Clearinghouse, which is a mechanism to enable governments to trust in the digitalized health and data content and interoperability functionality of digital solutions, linked to technical assistance and resourcing for common health system requirements. Next slide. And we're also excited about the imminent launch of the Global Initiative on Digital Health. It is a new global coordination mechanism to amplify our shared priorities and align investments in digital health and data systems with partners across the ecosystem, including many of you here in this room. Next slide. We're moving together into what I would call a hopeful future, where limited resources can be used efficiently to enable local capacity, strengthening health system resilience to deliver promised services and collect high-quality data, delivering health for all. Thank you so much.
All right, thank you so much, Alain. That was excellent. And now we have an online keynote from Yoon Seok, who's the Vice President, Data Department, National Information Society Agency, and Chief of Data Dam Project from South Korea. Thank you.
Hello, everyone. My name is Yoon Seok, and I'm an executive principal in National Information Society Agency in Korea. I am very glad to have a chance to share my thoughts on data in the field of health. Recently, AI has emerged as a key technology, and all countries around the world focus their national capabilities to secure a large amount of good data on AI. In particular, the medical field is drawing a lot of attention as the most promising field in the AI era. Then how can we create a large amount of good health data? I would like to point out 3 infrastructures that must be established first. The first is the system infrastructure that can produce, collect, process, store, and most importantly, share health data. The second is human resources. Diverse data experts such as data collectors, pre-processors, quality managers, analysts, and visualization experts are required for creating good data. The third is governance. It decides how to organize, access, and protect data. That's why it is the most important but hardest one to build. Let me give you an example of how great things can be done when we have these 3 infrastructures in place. In 2020, right after COVID-19 occurred, everybody rushed into pharmacies, waiting in a long line for several hours or wandering pharmacy to pharmacy to buy masks in Korea. The Korean government was able to resolve this national crisis in 2 weeks because Korea already had a nationwide system connecting all pharmacies on open data portal that can distribute pharmacy locations and the number of masks. There were plenty of app developers who voluntarily developed apps to inform people where and how many masks were available. The Korean government already established public and private data governance as well. They made a quick decision to share, open, and utilize data. We all know that COVID-19 is not the last pandemic, and we also have many diseases without the cures. From the COVID-19 pandemic, we learned that a pandemic cannot be ended by just one country doing well, but all countries have to do well. Sooner or later, data will become an infrastructure just like the internet. We know that we have made a lot of progress in various areas by communicating and sharing information freely through the internet. In the same way, health data will be used to develop new AI-based services to cure people. In order to develop better AI-based services, we must satisfy diversity and massive quantity on the health data. We can only achieve this by sharing health data together. Ironically, after COVID-19 pandemic, I've seen many countries change the policy direction from sharing to closing on health data because of national AI competitiveness or data protection. However, If we choose isolation instead of opening and sharing, we all lose in the end. Therefore, we must not forget that we always get better off when we open and share. I think it's a good time for us to prepare the universal health data sharing for our safer and better future. Thank you very much.
Thank you to South Korea. Thank you very much. And now in person, sitting next to me, but maybe you want to stand up, we have Steve McFeely, who's the Director of Data and Analytics of WHO and co-chair of the HDC Stakeholder Representation Group. Thanks.
Hi, good morning, everybody, and thank you for coming. So I was supposed to give a talk about SCORE, but in fact, when I was walking up this morning, I changed my mind. So if you look to the back of the room now, you'll see Craig just going, oh my God, what's he going to do? What I want to do is talk about SCORE, but in the context of health information systems. So when we talk about health information systems, what do we mean? Too often that word, it sounds like there is a system, and in fact there isn't. What we're talking about is multiple systems, multiple scraps of information. And these are fragmented. Samira mentioned the systems in WHO are fragmented, and that reflects exactly what happens in every member state. Our data are stored in different platforms, different formats. We use different classifications, different identifiers. Some data are digital, some are analog, and they're all in different states of aggregation. So, and then on top of that, we're using different sources. So we use census, we use samples, which can be either discrete, in some cases they're longitudinal, although that's rare. And then we use administrative data that has a lot more potential to link, providing those information are properly organized. So when we talk about integration, when we talk about interoperability, that's the ground zero that we're starting with, this mishmash of data that's scattered across different departments in different formats. A good start point is you can't share data if it's not digital. And I think this is part of the point that Alain was making. But of course, in many countries, they have a dilemma because electricity supplies are so erratic that there's a kind of a, what's the point of digitizing my data? Because then I can't get it. So, you know, they have to have an analog backup. And this is one of the challenges. All the time, we need to think about the infrastructure that supports our infrastructure. Other things that are forgotten too is to properly use this data, we really need to think about the data architecture and the data infrastructure. Too often the solution is presented as an IT solution, and the basic architecture is ignored. And this is a problem. There's other things that we forget too. We often ignore or forget the importance of legislation, the importance of interagency coordination, and the importance of culture. These are absolutely critical if we want to make differences. My first mission when I joined the UN was a mission to India, to a regional workshop. There was 9 countries there. And before I joined the UN, I worked in the Irish Statistics Office, and one of my specialties was linking administrative data, linking multiple data sources. And I was asked to give a series of papers, which I did. And it was a complete waste of time because my papers were very technical. I was dealing with the technicalities of how to link data. But in fact, as the workshop progressed, what I realized is the countries didn't have the soft infrastructure in place to get the data. So they didn't have the legislation in place. They didn't have the coordination in place that secured access to the information. All of my talk started from the assumption that that infrastructure was in place because I'd come from a country where it was. So I hadn't understood that this was an issue. So this was a real education for me. And I think too often we still forget about this. We focus on the technical solution. We forget about the basics. Another issue that I think that we tend to forget about, especially I think in WHO, is our mandate is health. So we tend to look at data from a health perspective. But health is not the most important issue in a country. It's one of many issues, along with education, along with finance, along with defense. So we're really only just one cog in a much bigger wheel that a country has to develop. So the the hypothesis that I put to you is when we're talking about health information systems and developing health information systems, the idea that a country can develop a health information system in isolation from the development of the wider public administrative data system, to me is ludicrous. It's highly improbable at best. So a country will develop all of its systems at the same time. So, and I think this is something that we tend to forget. And this is why the Health Data Collaborative is really important. It helps and reminds WHO to broaden our perspective, to bring in all of your views as well. And it reminds us that different aspects of health and other elements outside of health are just as important. And in fact, by improving the broader data system, we improve the health data system. So it's not a zero-sum game. It's actually a win-win if we look at it strategically. So back to SCORE, which is actually what I was supposed to talk about. Just very quickly, the idea of SCORE is very simple. It's an assessment of all of the data systems I was just talking about in a country. Where are you on the kind of development plane or the development spectrum? How developed are your systems? This is a high-level assessment. Using that assessment, we can then target particular areas that we need to dive in deeper and do further examinations. And that then allows us, in medical terminology, to conduct an informed diagnosis. That then allows us to target where should the interventions be, and that's what the tools piece is for. And it's really as simple as that. Thank you.
Thank you so much. Now we're going to move on to the panel. So maybe we can just everyone stand up and the panelists come here. Everyone stand up. We're going to thank you so much. We're going to quickly wave around so we all wake up. Right. So everyone shake, 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 shake. Move, 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 move. Thanks. Come on, you gorgeous people. I want to see all this movement from all over the world. You've all got your special moves. Okay, and then we need the speakers for the panel to come up here, please. So it's Nepal, Ethiopia, Botswana. Great, thank you. Sorry, please come, sorry. And also, just whilst we're on the subject of data differences, we are in Switzerland. And as you may have noticed, we're in a 1750 chateau little castle. So thick walls, sometimes there are problems with Wi-Fi and data here. And meanwhile, if you cross the road, you're at the state-of-the-art US Embassy with every extraordinary thing that you could have on a data level. So even in a rich country like Switzerland, we have very different places where you can, and levels of data and connectivity. So let alone in countries where you have thousands of, like South Sudan, for example, with so much space, and beautiful countries, but Wi-Fi is more difficult. It's happening everywhere. Okay, thank you. So we have our panelists. You don't have to be so squished if you don't want. Do we like them squished or do we want some more space? Huh? You're welcome to move a little bit, sorry, to have a bit more free space here. We'll just move it so that we're a little bit back. We have a bit of space, right? We're going to give you your mics. So this is where now we've had our wonderful keynote speakers, and now we're going to use the cowbell on our fabulous panel. So, where are we? You'll never know the sign of the cowbell. Sorry, this is mine. Let me get my papers. Okay, so we now have this is a really, really important panel, because this is where we're learning from the country experiences. What are the challenges and the opportunities, and what do they need partners do to help better? So without further ado, we have, maybe what I'll do is I'll ask the first question and then, so we now have 4 people. Okay. Sorry, I've been told I've got 3 people on the panel, but just a minute, let me see where we are. Sorry, this is a bit, so what countries? Okay, I know you're Nepal. You're Ethiopia, Nepal, and then Togo. Oh, I thought you were virtual. Okay, perfect. Great. Okay, excellent. And then we have Zambia. Botswana. Sorry. All right. Okay. So, Togo. Okay, perfect. Right. So now that maybe what we'll do is we'll start with the first question, which is what good practices in your country can you share where successful investments in health information systems and data governance have led to better health outcomes? And we're going to start with Botswana on Alain Seito Kokwe, who's the Deputy Permanent Secretary for Health Policy Monitoring, Evaluation and Quality Assurance in the Ministry of Health and Wellness, and co-chair of the HDC. Thank you. Go ahead.
Thank you very much. Good morning. Maybe just to start by saying in Botswana, the journey of improving health information system is ongoing. It's a real journey. We are not yet where we are supposed to be. Several assessments have indicated that we have a lot of gaps. And what we've been trying to do over the years is to try to close those many gaps that we have. One of the things that make us to look like we are getting there is the fact that as a ministry, we had a structure that is responsible for monitoring and evaluation and health information systems. This is a structure that was shared at a very high level of Deputy Permanent Secretary. And then in this department, you also have the relevant skills mix, although we know that human capacity, resource capacity continues to be a challenge. But the department brought together experts from public health, from monitoring and evaluation, from health informatics, and therefore it was quite a department that can really take the country somewhere in terms of developing the health information system. And this department is responsible for supporting the entire ministry. Therefore, it leads the development of the strategy for e-health, as well as the current strategy for digitalization. So that made it easier for us to be able to influence the entire ministry because we set the standards and we also coordinate the investment in terms of government budget, as well as the partners that are responsible for supporting health information systems.
Thank you. And now we're going to move to an online participant who is the Mwango Mutale. Do we have Mwango Mutale online? Okay, maybe we'll go to Ethiopia, sitting next to me.
I'm online. I'm able to get you.
Oh, okay, great. Sorry. Perfect. So Zambia, what is happening in your country then on the health information system?
Yeah, thank you very much. Maybe to start with, I don't know, are you able to get me?
Trying. Unfortunately, you've still got me on the screen, but we can hear you. So
okay,
whilst
awesome.
they figure out how to get you on the picture, maybe you can just speak. Thank you.
All right, thanks. Yeah. So thank you very much for giving me this opportunity just to share our experience on how we are performing in terms of data governance. I think for us, I must mention that we started this process some time back during the health reforms, and we have seen how we are moving slowly to get to where we want to be. But I must mention also that along the way, we've had a bit of challenges, but we are still pushing and hoping one day to get there. In terms of the good governance we have in Zambia, mainly they are largely attributed to the fact that we have now an M&D department within the Ministry of Health, which was created around 2016. Previously, we didn't have an M&D E department. We had a unit that was sitting within the planning department. But with the creation of the M&E department headed by the director, I think we have moved steadily in terms of improving health information system in Zambia. But also to mention that we are tapping onto the National Health Strategic Plan, which also feeds into the National Development Plans, into the SDGs in the area of health information by designing what we are calling the Health Information System Strategy that guides our health information system in Zambia. This is the first ever development of this document. And I think for us, it sets a pace and guides us on how we improve health information in Zambia. So I think that's what I can share for now. But we, as M&D, we work very closely with the ICT department. We support the ICT and issues relating to systems, introduction of systems or upgrading of systems within the ministry. We work alongside with the ICT department. I think that's what I can share for now from my country. Thank you.
Thank you so much. And sorry, when we next come back to you, I've been told that your video was not on. That's why we couldn't see you. So maybe when we come back to you next time, if you could turn on your video. Thank you. So we're now going to move on to Nad Wendrad, who's the Strategic Affairs Executive Officer of the Ethiopia Ministry of Health. Next to me.
Thank you. Good morning, everyone. So the health information system in Ethiopia, I think it's better to start, seeing before 15 years implementation. I have been working in Ethiopia in health information system for the last 13 years, and I have been witness for some of, successes as a country. So before 15 years, we couldn't speak about one indicator with agree of all partners and the donors working in the country, which is everyone has, parallel reporting system, and everyone has, reported different numbers in the country. That was the major challenge for the health sector. And we had standardized implementation of health information system in the country by developing, aligning all the data elements, starting from the source, from the capturing of the health information, the paper-based health information system and the routine health information system. So that gives the health, the Health Ministry of Health an opportunity to coordinate all the efforts in the country in health information system. That is a major success. And also, we have an opportunity to have built a capacity starting from the health post. Ethiopia is, a people living 110,000 million peoples, and a huge demographic with a disparity of equity and equality of health service delivery. So it gives us an opportunity to see what kind of health services are provided for the remote area of population in the health sector. So it gives the leadership of the country to decide on the data, specifically on paper-based. So that is a major one. The other one, imagine in Ethiopia, we have more than 22,000 health centers, hospitals, and health posts, which record health of the population every day. This data came to the Ministry of Health previously, before 10 years, one data from the capturing of the patient to reach to the Ministry of Health, it requires more than 2 months, Now we try to digitize this process, and we have introduced DHIs to 90% of health facilities provide their data routinely through DHIs. So this is really, really significant improvement for the health sector of Ethiopia. And the major success we can mention in this is the governance structure. We develop standardized health information strategy, digitization roadmap, and also specific governance structure, just like steering committee for health information system national level, and also advisory committee at national levels. And we have structural governance structure in each districts. And we develop performance monitoring team in the health facility to monitor and use the data in the health sector. So I think it's enough to mention this success in the Ethiopian. I can come the major challenges. Thank you.
Thank you. And now, very good. And now we're going to move on to Sarbesh Sharma, who's the Director of Management Division, Department of Health Services, Nepal, Ministry of Health and Population.
Thank you, Samantha. Good morning and namaste. Your Excellencies, ladies and gentlemen. Okay, thank you. Your Excellencies, ladies and gentlemen. For the data in Nepal, we have a health management information system that is going under the Ministry of Health, Department of Health Services, Management Division. There is one section called HMIS. So all the data that are generated from the health post level as well as from hospitals, they come to the DHIS2 platform to our HMIS system. And from that DHIS2 system, we are upgrading data, we are collecting data, and then research is also going from that data process. And in the same way, the administrative data produced when service delivered or activities performed, that make routine management information system for us. And for management information system, we have health management information system, that is one, and other is hospital information management system, as well as we have LMIS, that is logistic management information system. From that logistic management information system, we capture the basic equipments and medicine that has been provided to our remote places like health post, hospitals, and the data is generated from there. And we have a taboos also. The taboos means it is accounting budgeting system. We have that system also, and URs, early warning and reporting system by the EDCD. And we have IPD surveillance also, as well as MPDSR, means maternal and perinatal death surveillance review. So by this, we can find what are the mortality rate of mothers, where there is morbidity for the mother in family planning processes and like that. And we used to do census and surveys also. We have every 10 years, there is a national census. Just last 2 months, we have completed our census of government of Nepal. And we are doing our population housing census. We have a health demography survey, means NDHS survey. We used to do usually 5 years. In every 5 years, we used to do NDHS surveys. And we have a living standard survey also, and health facility survey, maternal morbidity and mortality study as well as. And we have a NHRC, National Health Research Council. The data which is generated from DHIS2 or HMIS system that is going on research also. So we have a research, and the Management Division, Ministry of Health is also providing annual health report yearly basis. So we have annual health report every yearly, and the we are reviewing an assessment of the report. So in this way, the sources of data we generated from the health post as well as from the health sector of Nepal. Thank you.
Thank you so much. So now we're very lucky in person to have someone from Togo, because I was told it was a man virtual, but we're delighted to have Dr. Emma. Sorry, if you don't mind, just I've got here Dr. Emma Asnamnam. Is that correct? And if you wouldn't mind just saying what your title is, please. Thank you. Sorry, I have your colleagues on my list. Thank you, but we're very lucky to have you.
Thank you so much, but I want to go in French. It will allow my country people to follow me clearly. Donc, comme je viens de le dire, je vais vraiment aller en français, et ceci va permettre à ceux qui me suivent depuis le Togo de pouvoir vraiment suivre assez aisément ce que je suis en train de dire. Eh bien, normalement, c'est M. Ouronile qui devait être là, et il est au ministère. Et comme il n'est pas là, je suis chargée de bien partager les bonnes pratiques en matière de gestion de données, investissement sur la gestion des données du Togo avec vous. Et donc, déjà, le Togo a commencé la digitalisation des données sanitaires et à travers le DHS2. Le DHS2, c'est le District Health Information Software 2. Et donc, ça a commencé progressivement en 2013. Et donc, ça permettait au départ de faire la surveillance de routine. Et donc, surtout pour les maladies à potentiel épidémique. Donc, à travers cette stratégie régionale de surveillance intégrée de la maladie et de la riposte. Et donc, pour ne pas oublier la couverture sanitaire, une application a été aussi mise en place, et notamment le School Assure. Et cette application était vraiment destinée à assurer tous les écoliers, les élèves et les étudiants inscrits dans une structure étatique de formation au Togo. Et donc, le Togo a aussi particulièrement saisi l'opportunité de cette pandémie de COVID-19 pour vraiment améliorer non seulement l'investissement en matière de gestion de données, mais aussi l'amélioration de la capacité de gestion des données en ce qui concerne les épidémies. Et donc, dans ce cadre particulièrement, le Togo a mis en place un certificat vaccinal de COVID-19 à travers une application native togolaise, et ceci selon les normes de l'Union européenne, d'Africa CDC, et qui sont fondées sur des données collectées et sur COVID-19. Donc, quand le patient ou bien la population se fait vacciner, quand vous recevez vos 2 doses de vaccination, vous avez votre carnet qui est disponible à travers une plateforme. Et tout ceci, c'est la plateforme DHS2 qui a été utilisée. Bon, je pense que pour le moment, je vais m'arrêter là, mais déjà avec le projet TAS qui est un projet de transformation des systèmes de surveillance africains, le Togo a mis en place, bon, ce n'est pas encore fini, et un mécanisme de détection précoce des maladies à potentiel épidémique. Et tout ceci pour pouvoir mieux faire face aux multiples menaces de santé publique actuellement à travers le monde. Merci beaucoup à vous.
Merci au Togo. Et maintenant, on va continuer la deuxième question. We're going to move on now to the second question. And in fact, I'm going to amalgamate the last two because you guys are such fabulous panelists. I know you're going to be able to answer them, and then we can open up to discussions. So what are the main challenges to getting good data to accelerate action for the health SDGs in your countries? And what can partners do to help you do all that you need to do with data? So what are your challenges and what can partners do that maybe they're not doing or that they should do better? Okay, on va commencer. We're going to start with Botswana, please.
Thank you very much. Yes, as I indicated, we continue to experience significant challenges in getting good data for decision making. One of the challenges is that we continue to have disjointed donor support, which undermines availability or access to resources. If we were able to pull the resources together, we could actually go a long way. So as a result, there's poor investment because of these disjointed efforts. We also continue to have a lack of capacity for effective partner management in terms of the country not being able to effectively put down structures that are managing the partners. As a result, the planning is disjointed, and therefore it undermines the health information system. Something that we maybe hardly ever talk about is the capacity of the leadership for data use. Okay, capacity of the leadership for data use. You know, whether when leaders are not demanding data that is going to be used for decision making, the quality of data will remain a very big challenge. So I think if our donor community can support beyond just the physical investment, but also the human resource capacity in terms of building the leadership that is needed, probably we could go somewhere. Thank you.
Thank you so much. So donors, I hope you're all listening online and in the room. We need you to coordinate better and be more cohesive. Great. Now we're going to move on to Zambia, please, who is online. Do you have your video, Zambia? Zombie?
Yes, yes,
we
I
make
have my
Zambia
video.
bigger. He's kind of in the corner up there. Sorry, we're trying to put you full screen because you look great, but you're a little tiny corner of the screen.
Oh, okay. Yeah. Thank you. I think among the challenges that we are facing in Zambia include issues of multiple reporting from various partners. I must say that we have different partners operating in different health facilities. As you may be aware, Zambia's got over 3,300 health facilities. And in these facilities, we have different systems that might be operating or are operating as supported by partners. So that in itself actually affects on how we report, on how we address issues of data quality. The other issue that we have is issue of hospital HMIS, which is still at its infancy. Quite all right, we have placed a few investments in the hospital HMIS, but it's not yet fully fledged operational. And the link between the community HMIS or the community data and the facility data still shows a weak link. So those are some of the major challenges that we are facing. And our plan and desire is to have a link between community health information system, the data that we are collecting at community level. It speaks and it runs all the way through to the health facility, but also to strengthen the hospital HMIS in terms of reporting using the ICD-11. We see some cases are underreported in these facilities because we have inadequate structures to support data collection and data reporting in the hospitals. The other major issues that we have seen over a period of time that data use is a big problem. As a means to strengthen this, we've been exploring ways to institutionalize into job descriptions of some of these program officers based at health facility to be able to use data as a day-to-day thing in their workplace or in their workplaces. So what we would like to appeal to our partners and lobby to our partners is the issue of having one reporting system. We understand there are different forms that are being used. Others are using the aggregate, others are using patient level, but we'd love to have that layer, the interoperability layer, that we're able to pull out different reports coming from patient records, aggregates, even electronic registers fit into this interoperability layer. And then from this one reporting system, you should be able to pull out whatever form of report a stakeholder would want, either a line list or aggregate or a summary, whatever form of report that they would want. So our focus is to have one national reporting system that will be answerable to all the stakeholders' needs. I think that's the submission from Zambia for now. Thank you.
Required in Zambia and beyond. Now we're going to move to Ethiopia. What do you need and what are your challenges?
Thank you. As I tried earlier to mention the major success area, we have a motto in Ministry of Health: one plan, one budget, one report, to have everyone in one line. But even if we embarked on this motto, we have challenged to, still we have a parallel reporting system in the health sector. Still, partners, donors, program leaders in the health sector even require separate health information system to have, a quality data for their program, which is challenging for the health sector. So there is a fragmented investment in health information systems still, and also, a fragmented parallel efforts to digitize the health information system parallelly. This is really a huge challenge for the sector. Even if we are working a lot to improve the health information system, the culture of data use is still suboptimal. We see an improvement at national and regional level, but in district levels, people's use data for reporting purpose, not for user, improve the patient care. So that are the major challenges what we are observing. We need to have, a new approach, humanistic approach to improve the health information system. What are the major factors to, to this data use? And the other one, data quality is still issue. Even if we are collecting a lot of and a bunch of data, we have an issue of completeness, an issue of accuracy, and an issue of reliability of the data. That people don't trust those data to use at national levels program, intervention creation. So this is a major challenge what we have. And there is a clear gap in the human resource of health information system. We need to work on that. It's not one-time work. We need to have an investment of a huge commitment, long-term commitment from partners, donors, and also a government. So we require a local capacity building on human resource, infrastructure. That requires a huge investment. And also we observe that a limited engagement of a private sector and also academia in the health information system in the health sector. So we require to bring this a huge support private sector and academia to work with the Ministry of Health. So we call partners and donors to support the ministry, specifically to improve the infrastructure of health information system, starting from the health post to national levels, and it require integration. I can mention some indicator and tell you that, we have immunization data, which is not integrated with, the supply of immunization vaccine. We cannot interlink and see how many of vaccines are provided for children. So we need, interoperable system in the health sector. And also we need to have, harmonized efforts, collaboration of working with partners and donors. And specifically, we require contextualized support as a country's, strategy and also a country's guidance. Thank you.
Great, thank you very much. So quite a good list there, supporting improving infrastructure, don't require parallel reporting systems, and the gap in human resources from the health post to the thing. But the thing I really like that you said was we're doing too much data collection for the purpose of reporting as opposed to improve patient health. That would be the takeaway quote. Thank you. Okay, great. So now we're going to move on to where are we now? Nepal.
Thank you. The challenges in Nepal is we have approximately 8,000 to 10,000 health facility in Nepal. So the reporting status is slightly poor, whether that is timely and as well as quality also. So main challenges is timely reporting of data as well as quality of data also, because the health facility, the health personnel, that is the health worker, they used to entry in a computer and then that goes to DHIS2. But in every health facility, we don't have a laptop and computers to record the data. Only approximately 4,000 health facility we have provided DHIS2 platform, but still there are remaining 8,000 health facility to provide DHIS2. Still they are working as a paperwork. We should try for a paperless documentation. One is that is the challenges. Other is we don't have a good human resources for the data management. So there is a problem in hospital because we have already upgraded DHIS2 facility, DHIS2 3 to DHIS 3.6, as well as ICD 10 to ICD 11. So if any services is upgraded, then it is we need a timely training for the human resources. So we have lack of infrastructure as well as lack of human resources, and we have a lack of budget due to the recession, to COVID, due to earthquake. So these are the problems in Nepal. right now. Mainly this time in Nepal, there is the budget is so less for the health sector. So if there is a less budget in health sector, it will be automatically less for an information system also. So the donor agencies like WHO or other donor agencies, external EDPs should help us for upgrading and for providing technical support for us. And we have a gap as well as capacity wise also. So mainly the main problem or the main challenges in Nepal about the data is we don't have a security of data as well. So the security of data is also very necessary. So we have to look after that because we have a lot of servers in a different helpers and different provinces. Because now the Nepal is a federal country, so there are 7 provinces. So every provinces they capture the data from the health post and the district level. So the difficulty in interoperability also. So one is the problem is that, and there is a lot of gap. So we have to fulfill that gap and go further for the benefit of people. Thank you.
Thank you very much. Any specific requests to these fabulous partners in the room? Come on, let's tell them what to do. Ask them.
For the partners, they have to support for addressing the capacity gap as well as for providing the technical support to the human resources who are working in the periphery of the country for the digital health. So I want that support from the forum. Thank you.
Great, thank you. So collecting data on paper makes it moving to digital difficult. Okay, great, thank you. And last but not least, maintenant on va passer à Dr. Emma de Togo pour vos défis et vos requests. Merci.
OK, merci beaucoup. Et donc, en matière de défis, et donc, les défis sont énormes, mais je vais juste prioriser comme on a eu à travailler là-dessus. Et donc, la toute première chose, il s'agit des infrastructures. Et donc, comme la plupart des pays de l'Afrique de l'Ouest, nous aimerions vraiment avoir une connexion Internet stable. Une connexion Internet franchement infaillible, et ceci à tous les niveaux de la pyramide sanitaire, puisque le DHS2 est dans tous les districts, et donc avoir la connexion même au niveau des formations sanitaires les plus reculées. Donc ça, c'est le tout premier défi. Et ça, vous voyez, ça dépasse carrément l'aspect santé, et donc le ministère numérique et autres, tout devrait être associé. Et maintenant, en dehors de ça, nous aimerions, ça serait bien d'avoir aussi au niveau des agents de santé communautaire des smartphones, minimum des smartphones ou bien des tablettes, et pour pouvoir vraiment faire une surveillance communautaire et plus efficace. Et maintenant, au niveau de la ressource humaine, que tout ce monde-là qui doit utiliser le DHS2 puisse être formé, donc qu'il y ait une formation et donc à tous les niveaux et de la pyramide sanitaire. Et ceci, il nous faudra de l'argent. Donc voilà là où interviendra les différents partenaires, et que ça soit sur le plan technique et financier. Et donc, voilà un peu de façon résumée les défis majeurs liés au système d'information sanitaire efficient au Togo. Merci à vous.
Merci. Et où est-ce que les partenaires ils pourraient aider un peu plus là-dessus?
Surtout au niveau de la formation des utilisateurs du DHS2, et aussi au niveau du mécanisme, du financement du mécanisme d'alerte précoce. Parce qu'il faut nous sommes en cours de mettre en place un mécanisme de détection précoce de tout ce qui est épidémie. Et pour ça, il faut payer, comment on appelle, il faut d'abord un contrat avec une agence de téléphonie mobile. Et donc, environ, ça coûte 42 millions par an. Et donc, il faut renouveler ce contrat de façon annuelle. Donc, il y a ces deux. Et puis, l'achat aussi des smartphones et des ordinateurs. Et tout ceci est la bienvenue. Merci beaucoup à vous.
Great, thank you. So from Togo, they're saying that the community health workers are also working on paper. They need to go digital with smartphones or laptops, and also the training issue. And and that there's difficulty, it's always very difficult to make deals with the big telephone companies. So that's an interesting one. I know in Nigeria on Ebola, they really made a great deal with the telephone companies on that. Okay, fantastic. So our panelists have been absolutely brilliant. Bravo. They did really well. They got their message across in time. And we're going to have a couple of questions because we've caught up on the time, and it'd be great to hear from you in the floor or online. So please, who would like, wave your hands, come on. Who would like a question, to ask a question? Come on. No one has a question, these fantastic panelists. No questions or comments. What about online? Great, thank you. Carolina, please read the question online. We have our online participants. Thank you for being so lively and awake. You're doing better than in our room, but we're doing brilliantly. Thank you. Online, we love your comments.
Okay, so from, I hope I'm pronouncing you correctly, Soyapi Lungu, do we have operational health information system technical working groups which may assist in overcoming duplications? And I repeat, do we have operational health information system technical working groups which may assist in overcoming duplications?
Did anyone want to start answering that?
Je n'ai pas bien suivi la question.
Tu peux dire en français, s'il te plaît, Caroline?
Ouais. J'arrive. OK, donc est-ce que nous avons de groupes de travail technique pour le Health Information System, pour le système d'information de santé, qui peuvent aider pour trouver des solutions pour les duplications? Duplications, c'est ça?
Éviter la duplication, mais je suppose qu'ils demandent au niveau national. Est-ce que vous avez des systèmes à l'intérieur? Peut-être c'est ça. Oui.
Oui, effectivement, au Togo, il y a un groupe technique de travail qui a été créé et sous le lead du ministère de la Santé. Et donc, l'OMS en fait partie. Et ce groupe technique a pour premier rôle de coordonner l'investissement des partenaires, et ceci va permettre d'éviter effectivement la duplication des financements, et ça permettra vraiment d'aller dans le même sens au lieu que chaque partenaire vienne et dise voilà, moi je veux ça, et qu'on aille dans tous les sens. Et donc voilà ce que ce groupe technique fait. Et même en dehors de ça, et le Togo a particulièrement un plan national de système d'information sanitaire. Le dernier plan couvre une période de 3 ans, donc 2023 à 2026. Et tout ceci avec des objectifs clairs et pour pouvoir permettre vraiment d'améliorer ce système d'information. J'espère avoir répondu. Merci à vous.
Oui, super. Any other panelists? Any other comments? Okay.
Yes. In Ethiopia, we have it. Not technical, we have a steering committee, which is directly led by the Ministry of Health, who has, all partners working on health information system, meets every quarter and see the progress of health information system nationally. And we have 3 technical working groups. These 3 technical working groups, one specifically focus on the data use, which is all data, indicator questions, indicator revisions, everything decided by this data use partners, each with engagement of government. The other one is digitized technical working group, which is, every partner working on digitization and on health information system, not only health information system, beyond the health information system. All these partners came up together every 2 months and led by the digital director of the Ministry of Health. And at the last, we have also a technical working governance structure for health information system, which is oversee all the structure from downward from the health, the health posts, health centers, region, zone, and see all health functions are working with, aligned with the health information system in the health sector. Thank you.
In Nepal, there is also a technical working group. The health minister secretary is the chairman of that technical working group, as well as all the directors. There are 5 directors in the DOHS. So all the 5 directors are members, as well as the DDA, Drug Administrative Division is there, Ayurveda is there. So every 3 monthly we have a meeting, and we have a meeting with the ETPs also. So ETPs are also partner of the are the members of that technical working group. So we are planning for everything for data as well as with them and discuss with them. So the chair is by the Secretary of Ministry of Health and Population.
Thank you,
Thank you.
Nepal. And sorry, we're just gonna, oh, sorry, yeah, go ahead. Sorry.
Okay. In Botswana, we established the Data Health Collaborative in 2020, and it has got technical working groups. One of the technical working group is that of data use, and the other one is digital health. So the data use is the one that is responsible for guiding data collection. They set the standards, and they make sure that they harmonize the tools that are used in the country. Let me also say the technical working groups are actually chaired by the stakeholders, and the ministry officials are secretariat to the committees. The digital health technical working group harmonizes the digital solutions and also facilitate the interoperability of systems to make sure that data is coordinated in the country and we have access to all the data that is available. Thank you.
Excellent, thank you. And we have a question here from Claire.
Thank you.
Keep it short, because I see we have suddenly the audience has woken up. I think the online people inspired our people in the room to wake up. Thank you.
Okay, I'll try and keep it really short. So that was incredibly interesting. Thank you all, and very strong echoes, I think, in your sort of in the agenda that came out from this set of presentations about the need for more coordination among donors, reducing fragmentation, investments in capacity and infrastructure, and that really echoes what what my colleagues here in relation to health, but also in relation to many other sectors. And I think we've heard also about the challenges of partnerships. So I'd love to hear from you all any incidences where you think partnerships are really getting it right. What are the good examples that we can draw on where some of the partnerships that you're involved in are managing to effectively overcome those challenges? Thank you.
Okay, so thank you. So good example where things are working, but if we could pass the mic please to the lady in blue, and we'll put a couple of questions together. Thanks.
Okay, thanks very much. My name is Rose Dlamini, and I'm based in Ethiopia. Just from the panelists, when you writing up your indicators, how do you get a good balance between the input indicators, the process indicators, and the outcomes? Because I sometimes see that there's a huge focus on process indicators, and then that takes away the attention from what we get for the outcomes. So how do you get that balance? And then I also hear a lot about the routine data, but I don't hear much about survey data. How does survey data, such as a demographic and health survey, fit into what we do and enrich our planning processes? And then also with the partners, how do you get partners to give up on indicators and data that they find useful, but we may not actually think is very useful? So how do you get that that convincing? Thanks.
Okay, thank you. So technical questions and about partners. Who wants to start? Nepal.
Thank you. You have asked that NDHS survey. The NDHS survey we used to do every 5 years, but the government doesn't do that survey. The third party will do that survey. The IRA Nepal, they will do a survey for us, and then we discuss the result of that survey as well as the report of annual health report of our management division. So the third party validate the research survey process in Nepal. And for the good example is we are in collaboration with EDPs as WHO, UNDP, USAID for the upliftment of DHIS2 facility as well as upliftment of the ICD 11 that will help for the general public, because in ICD 11 the parameters has increases because we have included mental health also in that and rehab also, mainly the road traffic accident rehabilitation process in that indicators. So we are integrating the data because we have a lot of data. We have malaria program data, we have HIV data, we have data of rehab also. So we are integrating the data from DHIS2, and we are planning ICT-11 is upgraded. The one difficulty in ICT-11 is that the doctors who are working in a periphery, they have a lot of people because we have an insurance of people also. So a lot of people, they are going to the government hospital for the treatment purpose. So we have a difficulty to enter the data because the doctors in a periphery, I think mainly 1 or 2 doctors working over there, they have to enter the data because we don't have a data analyst, data recorders, hospital medical recorders. We have less amount of hospital medical recorders. So there is one problem. Another is we are also planning for electronic health records in hospital. So we are in process of upgrading the digitalization system in Nepal. So it will so the developing partners will help for us. In this way we can go further. Thank you. Can I make your answer or not? Sorry for that.
Who else wanted to answer? Okay, go ahead.
Thank you. So any partnership as an example, I think I can mention the data use partnership, which is supported by JSI, Bill and Melinda Gates funded, which is a ministry really appreciate, which is, the direct support, aligned with the ministry plan. No extra requirement, embedded approach, no extra support. All staffs working in the ministry and support the regions focus on health information system. It is direct support for the health information system. We require such kind of effort at national levels. I'm not undermining other efforts and other partners, but this kind of system-based supports are, mandatory for the health sector. So I can mention that as an example, and also digitizations others. The specifically process indicators. I need to mention that in the Ethiopian Ministry of Health, we have health, one plan, one budget, one report. When we say that, that is a motto and a Bible for us. When we say one plan, every partner's donor country, the country needs to follow that plan. That plan should agree by everyone. So we put, everyone's engagement starting from the process of development. That is make it, not only the government plan, it is partners plan, donors plans, everyone plans. So we also agree with, how can we measure this plan? We put process indicators, output indicators, and impact indicators. For all those indicators, we said, how can we measure all those indicators? Some of indicators, outcome in specifically impact indicators came through survey. We agree with all partners and donors, 5-year survey, 2-year survey or 3-year survey, and a type of survey for each indicator defined on that plan. And we use specifically routine health information system to monitor the routine health, service delivery in the health sector, and that makes, makes some of, process indicators, some of in the outputs indicators, which is that we follow. So how, donors and partners see this routine health information system? That is the major question, because there is a gap in routine health information system. As Ethiopia, as I mentioned, it is a huge country. We have 2 types of data collection: paper-based data collection and reporting digitized. The data is collected paper-based. Only we digitize the reporting system, which is the paper-based data collection. We have a doubt, and when we have reported that, we have a doubt. When, in the process, we have a doubt. So we need a survey to confirm that, every 5 years, something with agreement, but to lead the sector, we use this routine health information system. Thank you.
Great, thank you.
Can I just add?
So
Yeah.
we have
Can I
a
just
question from South Sudan who've been waiting very patiently, and unfortunately due to time, they're going to be the last question, but I will then read out one comment that we've had online. And everyone else who's online, we do know you've asked questions. We're going to attempt to answer them. So please keep sending your comments and questions. They're really welcome and really appreciated. Thank you, South Sudan.
Thank you very much for giving me the floor. I'm John Romuno. I work for Ministry of Health in South Sudan. My question goes to Ethiopia. You indicated that you have one plan, one reporting system, but still programs have data management system. What do you think is the reason for the programs to keep data within the program when you have a one system? Thank you.
Short answer, because they doubt the quality of the data in the national health system. Even if it's a program based, the data will be qualitized because the investment for one program, the investment capacity building, everything is easy to manage because they tend to go there. But we are not here, for all health for population, not specific program. We need to strengthen with privileging this program to strengthen the health system. So we push them, as I mentioned, that one plan, one budget, one report is our Bible. We know that everyone will not follow the Bible. So some leakages are there, but we try to struggle and bring everyone to the on board. Thank you.
And part two of the South Sudan question.
Yes, thank you. My name is Moses Ongom. I'm from South Sudan, the WHO country office. I want to pick it on from the health financing challenge for information systems that was raised by Nepal. I just wanted to appreciate from the other countries how much domestic resources are being allocated for health information systems, because I think from experiences, countries usually find it difficult to project leadership and ownership if you're not allocating some amount of resources for a particular project or an initiative or program. So how are we allocating these resources? And I know those may not even be enough domestic resources. Then based on what we have channeled, how do we then ensure that partners' resources are then aligned to your priorities and synergize and complement the resources that we have already allocated for health information systems as government? Thank you.
Okay, I can see Togo nodding away. Did you want to comment? Togo.
Bon, c'est vrai que la question n'a pas été adressée au Togo. C'est un grand défi pour la disponibilité des ressources, surtout la mobilisation de ressources locales. Donc, c'est un énorme défi. Mais au Togo, nous avons la chance d'avoir le ISP avec nous et qui assure l'appui technique en collaboration avec l'Université d'Oslo. Et donc, pour tout ce qui est paramétrage et autres là. Et donc, mais le gouvernement togolais a quand même une part de responsabilité en matière de financement des ressources liées à la gestion des données et au système d'information sanitaire. Et donc, les partenaires comme l'OMS, l'USAID et la GIZ, je ne vais pas tout citer, ils viennent en appui. Mais je ne vais pas pouvoir donner avec précision le montant que le gouvernement togolais donne comme appui annuel. Merci à vous.
Zambia, we haven't forgotten you. Are you still online? Would you like to comment? Because you haven't answered to some of the questions. Is Zambia still there?
Yes. I'm still here. I raised my hand. I think my hand was not seen. Yeah. But I had a number of issues that I wanted to respond to. I think just quickly, there was a question on the survey data. For us, we are using that survey data, for example, the population data, we're using it for denominators to compute indicators in the DHIS2, but also for surveys like the ones we recently did, the HFFA, the Health Facility Assessment Service, we are using the findings or the updated data on GPS to update the data in the DHIS2 so that we're able to analyze data using maps all the way to the wards. So what we have done with the data that we collected during the HFFA, we are able to analyze data by province, district, constituency, as well as the wards within the country. In terms of partnership, an example that we can give on how we're collaborating with our partners is that we have agreed through the technical working groups, we have agreed that we have one reporting system, and efforts to move in that direction has started by identifying some of the equipment that is already existing in terms of computers, desktops that is existing in the facilities, so that we leverage on that partner procured equipment. We leverage on it as government to report using those equipment or those gadgets. But also in terms of indicators, how we arrive and set up for those indicators is through consensus buildings, sitting with the partners during the formulation of the national health strategic plans. We do these meetings, we brainstorm together, and partners identify those outcome indicators. We identify the input and all those related to the process indicators. By the end of those consensus meetings, we have an agreed set of standard indicators. Once we have those indicators in the NHSP, we now develop what we are calling the M&D framework that speaks to the NHSP. So using the National Health Strategic Plan M&D framework, we are able now to monitor how we are implementing activities that we had set ourselves in the NHSP. Also, working closely with partners, we have agreed that I think it's a common good that we go the digital way. Efforts of digitalization of the paper-based data collection tools has started and we are in motion. So I thought I could add the case of Zambia to the discussion. Thank you so much.
Thank you. So now I think Nepal.
Thank you for question. Nepal, they spend about 20 crores of rupee annually for the health management information system by government. They said gives a monetary fund of 12 crores per year, plus WHO 8 crores per year. Technical support from WHO for server, because we are just now the WHO have gave a server to HMIS system. National, it is about 20 crore rupee per annum, but due to recession, there is a decrease of budget this time. About 35% of budget is reduced in a health facility, in a health sector, because previously we have a 67 billion, I think billion or means billion of rupees. This time just 41. So there is a 35% reduction of budget in the health facility. So it will affect all the sectors of health facility, especially for the data also, because we know that better data is a better health. And other support for the research and survey by WHO. UNICEF supported for the logistic like laptops, screens and printers. And for the training, the quantification, DQHS quantification, everything is done by EDPs. So these are the support given by EDPs as well as government. Thank you.
Thank you. Botswana, did you want to comment? And then we'll have a comment from the floor and then we're going to have a break. Thanks.
Yes, I wanted to comment on the financing. To say as a government, Botswana spends a lot of money on supporting the health information system, like we support all other functions of the ministry. And we normally engage with our partners to the extent that sometimes we agree on the priority and then agree on how we are going to share the funding. So the funder can actually put in something and then the government will top up whatever the partner has put up. So in terms of budget, it's really working out very, very well because we budget for health information system within the national health budget. The partners also support a lot in terms of technical support, because that is where as a government we are limited and we depend on our partners to assist. In terms of providing computers, laptops and so forth, our partners are actually doing very well in that area. Meanwhile, the government as a whole is providing the network, internet connectivity to the entire country. All the health facilities are going to be connected through a project that is government-led. So in that way, we kind of meet each other halfway. Earlier on, I wanted to also comment on the indicators to say what we have done is to actually establish a very strong partnership and working together on developing the national indicators. And we agree on what indicators should go to national level and which indicators should remain at program level. So most of the process indicators are basically left at program level, while the outcomes and the impact go to national level. In terms of the surveys and so forth, we have what we call the data warehouse, which is a warehouse that collects all the data from whatever source that we have in the ministry. It might be electronic medical record, the surveys, all the data goes to the data warehouse. Thank you.
Thank you. So we're going to have a break, but just before, we have an anonymous attendee who has a comment. Why has no one mentioned donors being a major problem with data? They have so many data requirements that specific people are hired for collecting data and reporting to the donors. I know accountability is needed, but we spend too much money and human resources to meet donor requirements. Can donors at the very least get together and determine what minimum data are needed and move resources to actually provide health services? Thank you. And on that note, we're looking forward to a more lively discussion. We're having a coffee break. So thank you very much. Come back. Thank you to the panel.
Are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these Health Data Collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these Health Data Collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these Health Data Collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these Health Data Collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support Sustainable Development Goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more and join us. The Health Data Collaborative is a vibrant and growing community of over 220 partner organizations and more than 800 members from 7 constituencies. These constituencies are countries, civil society, private sector, donors, and philanthropic organizations, global health initiatives, academia, and multilateral organizations. Members of the Health Data Collaborative take part in several technical working groups. These include routine health information systems, digital health and interoperability, civil registration and vital statistics, logistics and management information systems, data and digital health governance, public health intelligence, and community data. Countries can use these health data collaborative assets to better coordinate technical support. The aim of this community is to align technical, advocacy, and financial resources with government priorities for data and digital development. The importance of this work has been underscored by the COVID-19 pandemic, which showed the risks of fragmented data systems posing a significant threat to coordinated action and response. The Health Data Collaborative, together with the Sustainable Development Goals 3 Global Action Plan data and Digital Accelerator, is designed to support and streamline existing processes to align resources with government data and digital priorities using existing structures and processes. This is done through capacity building, knowledge sharing, and country peer review of data challenges and opportunities. By embracing diverse views, perspectives, and backgrounds. By promoting the highest standards of data security. And by promoting health data as a global public good. Aligning global tools with local contexts and needs is crucial to support sustainable development goals monitoring and contributes to health information systems that are clear, concise, and actionable. Learn more from Yoon.
So have we got everyone in the room? Hello. Oh, I'm going to do my cowbell again. It's not very loud. I have to say normal Swiss cowbells are much louder, but anyway, great. So are we ready? Take your coffees, teas, sit down. It looks like we're missing a few people. Have they gone walkabouts? Do we know where everyone's gone? This table? Okay. So, where are we now? Right. We're only running a little bit late, so this is good. Okay, so we're going to move on to the next session, which is all about partnerships. Les partenaires, how to make it work, what can we do better, and lessons learned. So we're going to start, we have a video from Kenya, which we're going to start with on the power of data in the community. Thank you.
When a community health volunteer goes to a household, they register the households. Is there an expectant mother? Is there an under 5? Is there people with diseases? So it is my responsibility to look at the data, interpret data, analyze what has been collected, and plan for any action depending on the data that was being collected.
My main responsibilities in my community is to visit my households and to make awareness, like to talk with the young mothers and the pregnant mothers on how to come to clinic and how they can bring their children to clinic.
We have 10 CHVs in every community health unit. So that means for the 28 community health units, that is 280 CHVs. 280 CHVs, each of them take care of 100 households.
Yeah, it is difficult. The workforce also, we are very few who are supposed to collect all that data, put it together, interpret, understand, put it in the DHIS, go give feedback to the community. At times most of the time it is a very big workload.
It's a lot of work. You cannot even know which was where most of the time, but it's true, it's a big bulkage of papers.
How I would wish if actually everything was electronic. That would have been so good because it would actually also help us sieve and figure out and give us the exact information or help us in analyzing the data that we have.
So it will be my prayer if the government to come down on the ground and see the need, because we are serving a lot of community and a lot of things are happening. So one person is not able to maneuver all this work.
The volunteers, wow. Wow. The volunteers play a very big role that cannot even be measured through the data that we put in writing. The volunteers have changed humanity. They've actually helped the people down there in the community.
I'll continue because that is my talent. Because it is inside my blood or inside my body. I'll continue and continue until my end of my life.
Okay, thank you to Kenya for the video. And now we're going to move to Malawi and Nepal. Do we have, one of them is online and one of them is in the room. Who do we have in the room from Malawi or Nepal?
Thanks, Samantha. Unfortunately, we don't have anybody that was with us during the mission at the time, but I'm happy to say a few words just on behalf of the SDG 3 GAP and the Health Data Collaborative, just outlining some of the activities that took place last year, referring to the joint missions that took place to Malawi and to Nepal. So there should be some slides, Karim. So again, just by way of background for our colleagues here who may not be aware, the Health Data Collaborative and the SDG 3 Global Action Plan Data and Digital Accelerator jointly took part in a number of different country missions with overall aim of supporting both CRVS and GIS systems in different countries. We traveled to Malawi in June 2022 and also to Nepal in January 2023. And the reason why we decided to travel to these two countries to focus on these two specific is simply because one of the principles of our engagement with countries as the Health Data Collaborative is that we try to be always as opportunistic as possible. In regards to Malawi specifically, we recognize that the score assessment for Malawi showed that CRVS was particularly lacking in many areas. Partners also recognized the potential for GIS across supporting all areas, not just the health-related SDGs, but many others as well. And at the same time, we leveraged on ongoing collaboration between the WHO's GIS Center for Health and also UNFPA's ongoing work on both CRVS and GIS. So indeed, as mentioned, we traveled to Malawi, supporting some of their systems there. We drafted a white paper on Malawi on how to improve both CRVS and GIS systems in Malawi. The white paper was launched in New York a few weeks ago in April on the sidelines of the UN Commission for Population and Development. Pertaining to Nepal, I think we had a really wonderful experience in Nepal, and thank you to the colleagues here who welcomed us so warmly. Again, jointly, 3 agencies, WHO, UNFPA, and UNICEF, led this mission that went to support CRVS and GIS systems in Nepal. One thing that particularly stood out for us is the richness of community health workers in Nepal, and they call them female community health volunteers. But again, the key takeaway here was really trying to engage the entire system, engage the community and anybody else that could support us in our mission to support the government of Nepal in improving CRVS and GIS. Again, we do have some specific follow-up action points out of these 2 missions. We look forward to disseminating these later on, but this really just showed the power of this type of collaboration that could take place amongst different agencies supporting different governments. I don't know if Craig wanted to add to that.
Thanks. It would be good to hear from our colleague from Nepal if they have any comments specifically on the joint support in a partnership model for CRVS and GIS, but that's all. Thank you.
Thank you. We have a CRBS plan this year for birth registration as well as death registration. That is from cradle to grave. Previously, we used to have a paperwork for that. Now, Static Bureau of Nepal, with collaboration of Ministry of Health and Population, this year we are going to start CRBS also. So that will help a lot about the what is the condition, whether the population has birth rate policies as well as death also. So this is a good initiation, and this CRBS is supported by WHO. So thank you for WHO for providing Nepal as a working on a CRBS.
Thank you. Moinia, did you finish or? Okay, thank you, Moinia Kasonde from WHO Data for that presentation. Okay, so now we're going to move on to David Novillo Ortiz, who's the unit head of data and digital health of the European WHO office. Here he is, great. So can we get this to work? Yeah, it should work. Okay, great. Yeah, as you like.
I would prefer. That's fine. I will stay here. Yeah.
Is that okay?
Yeah.
And then you can look. Is that good?
Yeah, I think so.
Is that good for the cameras?
I can see that. So no worries.
Yeah.
I can just do it. Yeah.
Okay.
Sorry. Yeah.
You've obviously got better eyesight than I can. I can't see this. Sorry.
Yeah.
It's like minuscule. Is that all right? Okay.
Thank you so much. You're a wonderful facilitator. Good morning, colleagues. So I have 7 to 10 minutes, and I trust that Amanda will keep me on track. So what I'm going to present briefly today is about what we're doing in WHO, in the European region. Full disclaimer, when we refer to the European region, this represents 53 countries, nearly 900 billion population. So yes, million population, my apologies. So we're almost 1 billion population, okay? Next slide, please. There we go. I have structured this brief presentation into components, background, and then some comments about how we can improve the investments on health information systems. Next slide, please. Okay, so we're talking about data, we are talking about, there we go, today is my day, improving health information systems, data, etc. Okay, let's make a reality check, right? This is the current situation about data availability about the SDGs. We're in 2023. We should accomplish all the SDGs by 2030. And there is no way that we can accomplish that without data. And this is the current situation. When it's about health, we can say that we are more or less fine, but this data, when we disaggregate the data and we look at the different regions, the access to data and the availability on data is quite different. So this is the starting point. We are talking about policy decision-making, how we can change health, how we can improve health, but this is reality. So we are making decisions without having data. And that is something that we need to more and more, this community, that we're all working on data and health information systems, in making and repeating this point again and again. It's time that we have the opportunity to represent this reality. Next slide, please. We have learned a lot during the pandemic. I think that, thank you, more than ever before. We have seen how we have struggled calculating the data, how the data was defined, how the data was used. We noticed that we didn't have enough health workers with data skills to operate with the data. So it was the perfect storm in the middle of an emergency at the global scale, not to have the possibility to really improve data and health information systems. So we have learned a lot. My concern is like, even though we have learned a lot, we are just already forgetting about what happened during the pandemic. And that is a clear risk for what can come next. And I am really, again, extremely concerned about this, and that data, again, is neglected. We invested a lot in health systems during the pandemic, but now I can feel already, and of course I'm not going to quote any countries, I can feel already that the budget to health is again being reduced. And this is something that, again, all of us need to work together to continue repeating this point until someone is listening to us. So we know about data issues, about data problems, but also this morning, my dear colleague Alain, and we have been talking about digitalization. We have been talking about the importance of digitalization, but I would like that all of us have this in mind, right? So when we try to digitalize data and information systems, if you digitize a broken data process, what you have in return is a digitized broken data process. So we know about this fever to digitalize, but we need to address and tackle all the data issues before we move to digitalization. And that is something that sometimes we forget doing. Very quickly about the second part of what we can do, what we're trying to promote in the WHO European region when it's about data digitalization. We have these three questions: where we are, where are we, and where do we want to go, and then how we're going to get there. Very briefly, so we know about the tools, available tools. SCORE, all of you are familiar with SCORE. It's the tool that we have used to know how data and countries are being performed, and it's a global scale. It's a wonderful tool. Then we have other tools. In the case of the European region, we have a slightly different tool that is how to assess health information systems, looking more at a qualitative point of view. So we, apart from knowing the problems, we know the reason for that problem. So then we can propose a proper plan to all the countries that are applying these tools. And there are some other tools related more about digitalization that I think that we are not using enough. But definitely, we should assess first before we move investing in data. The second point about where do we want to go? So we have all the fragmented data, and at the end, we just want to improve population health, right? So the only way is having a structured plan. Okay, this is what they would like to be. This is the final goal for all of us. So we have actionable data that we can use for improving health systems, but also for improving health as a scale. And the final part, and I am concluding with this, is what we need to do, how we can do this. So there are a few steps that we can take forward and that we are promoting all the time. The first being developing a data governance framework. So it's impossible that we can address data issues without having a plan and a governance mechanism in place. It's impossible. You cannot tackle NCDs, you cannot tackle communicable diseases without a plan. And with data happens exactly the same. We need a governance framework, right? Apart from that, we need to invest in data infrastructure. This is something that is very neglected. And in all the SDG reports, I have monitored the last, I will say 5 to 7 SDG reports. You can look at all of them and data is always neglected. And all the problems in that report are always the same. And I don't think that we are doing enough to really address these problems. Third, we need to do better when it's about integrating data and information systems. We work in silos, right? And it's very difficult when we are supporting member states. You have several hospitals that they're not connected, they don't change anything. And it's very difficult to move forward, improving data flows. And to be honest, I think that we have a responsibility here from a government point of view, from a UN point of view, from all the partners about how we do things. One of the main problems that we have is that when talking about data and digitalization, is that most of the time, the private sector is moving without the public sector. What's the reason for that? From my point of view, what I have seen so far in the so many years, I'm not going to say how many working in this area, is because we don't say to the private sector what we need. That is the reason the private sector is coming with solutions that maybe they are not fit for purpose for what the public sector needs. So that is on us, right? So when talking about integrating information systems, we should also look at what we need and be clear with the private sector. I can see that in the digitalization portfolio. That is one of our portfolios in Europe that I had the pleasure and honor to manage. And I can see how countries, when they have very good defined standards The private sector is welcome to join this and not the other way around. So when we leave the private sector deciding on behalf of us, usually we are setting the project for failure, regretfully. And I don't blame the private sector for that. It's just we need to work better together. And finally, there is a lot of non-traditional data sources that we need to use. I don't know if all of you know, but we have a data lag for WHO when we collect data, mortality data, etc. There is like a 2-3 years data gap, data lag, right? So the data that we are showing this year is from 2 years ago. Best case scenario, right? So we need to be innovative, we need to be creative. I know that Samira, Steve, Craig, and the team are already thinking on how we can improve this, looking at non-traditional data sources. The challenge is how we're going to combine our evidence-based approach as a WHO with what is happening outside. That is going to take us time, but maybe working together, we can do better. Thank you so much.
Very much. And top marks, you're actually 3 minutes early, so very good. Okay, so now we're going to move on to the panel, where we are going to be looking at the panel. Sorry, I seem to have lost the name of the panel. Hold on. Sorry, talking about paper versions of our digital knowledge. I'm referring back to my paper because sometimes paper is the most reliable. Right. So we've heard about the importance of the need for a governance, a plan, and data infrastructure. Thank you for that presentation, and how the private sector and public sector are often going at a different speed. So now we're going to have a session 2 on data governance and good practice. So could everyone please who's in this panel come forward? Thank you. And if you don't have your name tag, if you could bring it with you, please, so that everyone knows. Thank you so much. Excellent. Now, we're going to get water for everyone. Okay, perfect. So the system here is going to be like we did before, where we have questions, and then we have the cowbell, which I need. Can you get me my cowbell, please? And this is, so if you go over time, you have 2 to 3 minutes each, and we've got 3 questions. So data governance and good practice, right? So what needs to happen? So the first question is, can you share some good practices in governing data collection, storage, sharing, analysis, and use in your country, please? And we're going to start with Pakistan. That's not it. Sorry. Data governance.
You're in session 2.
Oh, sorry. Sorry, folks. Okay. So there's a reason why we're in the chateau, right? We're sort of, we really are on our paper version here. Thank you. Okay, we're here. Great. Thank you. Sorry. Okay, the correct panel is approaches of country and partner collaboration. Right. Is that the panel you're supposed to be on? Excellent. Okay, so, okay, so from your constituency's point of view, from what you have just heard, what opportunities do you see to partner and invest for better data governance and HIS for country PHC, UHC, and SDGs. As you know, the UN and many partners love all these acronyms, but presumably you all know what they are, right? Excellent. So we're going to start with, who should we start with here? We've got representatives from the multilateral and international organizations, bilateral donors, civil society, global health initiatives, private sector, research, academia, and technical networks. So maybe we'll start with the bilateral donors, as we ended with a comment to the donors. So we have here Ernesto Lamke, who's advisor, sector initiative, global health, okay, I can't pronounce it, GIZ. It's the German technical agency, which is now calling itself GIZ. Thank you.
Yeah, thank you very much for having me here and giving me also the opportunity to share some of the views of the bilateral donor constituency. Yes, so what we heard this morning, we saw like a lot of needs and potential where we can address also these needs. And I think as donors, what we should really bear in mind is really looking and collaborating with countries and work really at the country level towards these needs that were clearly stated here. And I think what we are lacking from our side, because the donors are implementing projects on a 3 years basis and looking really on to fulfill their own indicators. And I think it's really needed also to strengthen the space that we have here, the Health Data Collaborative, to engage more with countries. And I think what's really important here, also from the HEC side, is to look how we can really enhance the structures of the HEC within country level. And I think, the colleague here from Botswana, from Ministry of Botswana, really stated, and I found very interesting, that the Health Data Collaborative in Botswana is working very well, and they have also, and as I understood it, an own chapter of the HEC. And I think this is something that can be replicated, and we should use the regional focus that some of the donor organizations have to leverage the HEC mission towards these countries on a country level. I think that would be my contribution for now.
Thank you very much. So now we're going to move on to the multilateral and intergovernmental organizations. And we have Malavisi Virapan, who's the Senior Data Manager and Program Manager of the World Bank.
Thank you. So I wanted to first acknowledge the excellent panel that preceded us. I think they touched upon several of the points that probably I'll raise. And from the World Bank perspective, the way we are looking at this is there's never actually been a moment like this before. To harness the potential of technology, data, different systems to accelerate health system transformation. I think the previous speakers actually spoke about the lessons that we've learned from the pandemic, the momentum around SDGs, the G20's focus on data. There's just so much momentum around how we use data, how do we embed actually digital and data in our health system transformation processes. Investments in health systems are happening, but how do we bring digital? How do we embed them? I think there was a lot of discussion also around, it's not about technology. It's about technology, but it's not only about technology. You want to see how it directly impacts how we provide patient care, how it directly links to health outcomes. But then how do we use these digital technologies in our health system transformation to bring about that kind of change? So how do we use existing investments, or how do we design our new investments by embedding digital and data more systematically? I think from the World Bank perspective, we're taking this digital in health. We believe that similar to banking, nobody says, I'm going to go and do online banking anymore. It's understood that you use digital technologies. And we think that in a few years, this whole concept of digital health will not cease to exist, and digital becomes embedded in healthcare transformation. So that's the kind of opportunity and thinking we have in the World Bank, and how do we systematize this in our investments and engagements with countries, and also in the global stage, how do we link our efforts with other partners? And I'll maybe probably, I don't know if the cowbell is going to ring, but maybe 3 areas where we see real potential. Again, this is linked back to some of the discussions that happened before is, one is data capital, and that includes both physical capital and human capital. That went back to this discussion around improving technical capacity, literacy, digital data literacy, really improving the use of data. And the second is physical capital, which everybody talked about, which is connectivity, but also about how do you get more people connected to the internet? How do you really digitize systems? And the second is, Alain talked a lot about this in terms of technology and the interoperability before, and also actually the previous speaker, David. So it's about how do you bring a more systematic thinking about bringing different types of data together, integration of data, this more enterprise architecture approach to bringing digital and data into health system transformation. And the third is better integration around standards, taking a really standards approach and bringing, again, all of these 3 into our investments is the opportunity that we have today. Thank you.
Thank you. So health outcomes, interoperability and standards. Now we're going to go online to the Global Health Initiative. Steve Ollis, Project Director, Country Health Information Systems and Data Use, JSI. Chisu. Do we have him online?
Hello, can you all hear me?
Great. Yes, go ahead.
Great. Thank you so much for the opportunity to participate virtually. It's a pleasure to be on this panel and represent the Global Health Initiative. So just a few points, and as has been mentioned, there have been a lot of great speakers that have gone on ahead of time, so I will be echoing some of the things that we heard earlier. But just to point out some of the opportunities, I think we've heard the discussion about digitization, and that's exciting. But what we're also hearing is countries want to go to digital transformation. And so to do that, we need to invest in and coordinate around these foundational supports that have been touched on. The systems are important, yes, but that infrastructure, the devices, the connectivity, the human resources, and the change management processes, which are not nearly as shiny and not nearly as appealing as some of the technologies, but are critical to do this. Another key thing to invest in is to support the governance, these coordination mechanisms that must be government and country led. These are critical to help coordinate partners and particularly also to help coordinate amongst different government agencies that are critical to be able to enable data sharing and sharing of processes. So some of the foundational things that are needed that can also be supported and come together on are around supporting strategies, costed roadmaps, and action plans. And getting to that point is great. And then we need to continually invest in then monitoring the implementation of these things because things change. And to be sure that we check day to day, week to week, month to month, how the implementation is going and where there still may be gaps. We also need then flexibility. We need to have flexibility in how we approach these things because often projects are designed based on an assessment that was done 5 years ago, based on a project that then came to be 4 years earlier, based on a work plan that was put together 2 years ago. And again, there are new opportunities that pop up. And so we need to have the ability to be flexible in our approaches so that we can continue to add value with our government partners. Another area for investment and opportunity is to invest in knowledge sharing platforms, both in country as well as regional networks and global networks. So particularly groups like AHIN, Rekainsa, Helena, and the Pan-African Health Informatics Network that's being established through Africa CDC. These are some key components that really can act as glue to sharing best practices and knowledge. And another component, just to touch on Alan's famous slide around pilotitis of systems. I think we've done a good job of coordinating and avoiding some of the fragmentation on digital systems. Where we now need to focus our efforts is how we can coordinate and standardize around data use and data visualization approaches so that we're not fragmenting on that end of things as well. And would really love to hear more about some of the approaches being taken by the Botswana Data Use Working Group, which I think could be a very interesting model. Thank you.
Oops. Oh, yeah. Thank you very much. Okay. So now we're going to move on to civil society next to me. Kristen Matheson, Policy and Advocacy Lead, Transform Health.
Thank you. Yeah, so I think from what we've heard from the previous conversations, we've really heard a lot about, the importance and the need to strengthen and invest in health information systems. So really around the collection, monitoring, interoperability of data, reducing fragmentation, which is really critical for better data-driven policymaking and decision-making. And the opportunity this holds for improved health outcomes, which will only increase the more as our health systems become more and more digitalized. But what we really need to equally focus on is the importance of strengthening, investing in the governance systems around that. So we've been hearing it from some of the speakers, particularly David earlier talked about, data governance frameworks, but the need to really invest then also in the health information systems, but also the enabling environment to make sure they're working and responding to population needs. So really investing in the legislation, the policies, and the frameworks, and really strengthening the regulatory environment around the governance of health data. So we heard earlier from Claire as well, who really, I think, said it really well around, we need frameworks to protect people, to establish standards and norms, and to really establish public trust in the health data systems, which is critical to ensure that that data can be used for better public good and health outcomes. So an area that we think is a really important opportunity to be able to invest in strengthening the regulatory environment is around the development of a global health data governance framework, which would really bring countries together through a bottom-up approach of what is needed. What are those common standards that are needed to better regulate the governance of health data that's very much country-driven, but can really then, through a global framework, build the consensus around what is needed, that can then in turn help support with national legislation, as well as importantly, as the pandemic has showed us, we knew before, but it's emphasized even more, the importance of data sharing across borders as well to improve health outcomes and impacts. But it's also really through a global framework, it's really an opportunity to also look at new approaches to health data governance that are very much patient focused, that balance the needed protections around people's data, while also ensuring that that data can be shared to help improve health outcomes and the public good, and really to ensure that when we're looking at the governance of data, we're very much looking at centered around equity and rights, because it's people's data we're talking about. They need to be their considerations, their equity, the rights, that needs to be central to any frameworks, any discussions around that, which is really important, will deliver more equitable health outcomes and greater progress to UHC and the SDGs. And if I have time to just add really quickly, which I think is really important and aligned to this, which actually Steve mentioned a bit previously, is around, the coordination around that and increasing having the investment around the coordination around that as well, to really reduce the fragmentation in terms of approaches, and to really kind of build on lessons and experiences and help build that consensus, and ensuring as well that we're really investing in inclusive approaches around this as well. So very much a partnership approach to really leverage and build on the experience, expertise, and to really build that buy-in, ownership, and trust from different stakeholders, including, really importantly, civil society and communities, because ultimately it's those communities' data that we're talking about, and they need to be part of those conversations. And then just also really increased investment, a really important opportunity to invest in the systems, improve systems for monitoring and to uphold action and implementation.
Thank you very much. That's brilliant. Okay, so now we're going to move to the private sector. At the end of the table, we have Vikas Dwivedi, who's the Senior Health Information Systems Advisor of the Palladium Group. Take it away.
Thank you. Good morning, everyone. Sorry, good afternoon. My name is Vikas, and on behalf of the private sector, I just, like you said, Samantha, the private sector is always at the end of the table. So I think the private sector should be included as part of the community and as part of the team, as an overall health system. I think that there needs to be a sort of a new, I don't know, not to say a new definition, but the new way of working on how we can better collaborate with public and private. So it's all becomes one health system. So in terms of data specifically, private sector data, public sector data, that all needs to come together because it's my data. If I, as a citizen, I am the data owner. I go to a private hospital or a public hospital, but it should be my data, right? So that overall, in between private and public, we need to bridge that gap much more efficiently and closely. And I think this is a couple of years back in the logistics supply chain world, there was a quote, a statement that was very famous, and it was something like that. I may not have the exact words. It said, if there is a Coke, why there is no condom, right? So if a private sector company can supply Coke to the remotest areas of the world, and I have been to some of the remotest areas of the world and I've bought Coke there, why cannot a condom reach there or public health services reach there? So just to kind of in the data and digital world, I think there are good examples in the private sector that we can work together with the public to build again a stronger health system and a stronger data system. So it may be again kind of coming back to a stronger collaboration mechanism so we can all work together. And also to the point mentioned earlier on the learning, right? So either it's in country, either it's at the regional level. There is definitely, we need to better learn on what's happening again in India, where the private sector is much stronger. 80% of services are being delivered in the private sector, and how that data is coming in the government sector, in Ethiopia or Africa or any other country. So that learning country level, regional level, that really needs to be much more stronger. And previously, I know David just blamed the private sector earlier, but thanks for that. I think we need to build on that issue, that how we can best utilize that in our favor and build an overall a stronger health system. So I think I'll stop there. Thank you.
Thank you very much. Just so that you're aware, you're actually on the end of the table with civil society.
We should cover it up. Yeah.
And also interesting that you bring out the Coke example, because actually that was 25 years ago. We used that for HIV, for essential medicines about Coke. And we're using it 25 years later now on essential data. So interesting parallels. Okay, thank you very much. So now we're going to move on to, last but not least, research academia and technical networks. And please be as concise and to the point as possible. I know you're an academic, but thank you.
I think I'm actually part of the technical network from the, or maybe also having a hat, but I'm happy to speak. In terms of, how do we make better opportunities for partner investments? So it's a bit disheartening because at CDC, at the technical level, at the digital health, that community, I think, has come quite a long way in aligning. You heard some of that spoken to earlier today.
Sorry, can you put the mic close to your mouth?
Sorry, Ellen spoke eloquently about the smart guidelines and the need to digitize care. We heard about enterprise architecture a lot. And yet, despite the fact that you're seeing these kinds of strategies reflected in digital health plans really across the globe, 60+ countries have them. And I think that in terms of vision, I think they're well aligned. Regardless, when you hear the reality on the ground, the issues of silos, of burdensome reporting, of lack of data use, which I've been hearing about for the last 15 years, are clearly still problems. So I think that the challenge for those in the community that are providing technical expertise is to keep the reality in mind and then think about how we bring people up from where they currently are. I will be presenting a little bit this afternoon about what CDC is doing to do in this way. So I won't repeat that here, but But many of those issues really resonate: improvement in capacity, better integration of data, better ability to automate data from reportings to reduce the burdensome, better adoption of standards, use of cloud technology, which actually hasn't come up yet. But I think as the technical infrastructure around us improves, we need to think about how to take advantage of it and how to plan a bit into the future about what the technological landscape is expected to look like. And central to this conversation, improvements in governance processes, balancing the need to share data with the need to protect the privacy of individuals, and then the workforce improvements at every level, at the worker bee level to be able to better use data and take advantage of new analytic tools, but also at the leadership level. How do we empower people to make effective decisions about technology, about planning, about design? Anyway, thank you for the opportunity to speak, and I'll talk more about these issues in the afternoon session.
Okay, thank you. So we're going to move very briefly on to the second question. Then we have some questions online, so we're going to go to those. So if you all fabulous panelists could keep it as, that was very good. Thank you, Samantha, keeping it as concise and to the point as possible. The next question is, what do you suggest to improve collaboration between partners and country governments that link data in health outcomes? So we're going to start again with GIZ, representing bilaterals.
Yeah, thank you very much. I mean, what we should do, we heard about the private sector and also the difficulties of the domestic private sector to enhance the technological capacities and development of, for example, global public goods. And I think this is something that we should leverage and also like focus on to really enhance the capacities within countries so they can develop their own context-specific technological outputs or solutions in health information systems, and also this can also facilitate the integration of systems within country level. And for that, I think the private sector from the global north can help and assist. But we should also bear in mind that we should really need to enhance the capacities within countries. First of all, because it's needed and it has a more sustainable character in it, so that the private sector in these countries can really complement what is needed within these countries. Thank you.
Thank you. Now we're going to move on to the multilaterals, World Bank.
Thank you. I wanted to follow up on the point that Zen made around innovations that you're seeing in different countries, the different types of digital solutions. And that's really true. It's opening doors to new business models. For example, in India, eSanjeevani is an example of a telemedicine service that actually delivered care to about 1.2 million patients in just 30 days during the pandemic times. And then you probably also have heard about other types of examples where AI techniques are used, especially in the radiology services in countries that are being more and more adopted. So some points that I want to make is around collaboration, is if there's a sort of a common set of approach or principles that we can all adopt, either it's country or the partners or private sector, in terms of how we implement, how we approach the health system transformation. The first is scaled up implementation, moving away from pilots to really having a continuity when it comes to digital transformation of the health system. And a big part of this is also with the governments. You know, we often see that with government changes, there's that need where these agendas or committees that are created are dropped, and we've seen successful implementation in countries where there's been commitment to the agenda, because these types of transformations take a long time. So really moving towards that scaled up implementation. The second is, I did mention this before, which is taking a standards-based approach. If every implementation follows a standard, the common standards for interoperability, with respect of who's implementing it. I mean, it's a bit of a difficult thing to say, let's get rid of fragmentation, right? I think fragmentation is going to exist, but it's more about how do you connect these disparate systems You have legacy systems, you're going to be building new systems, but the point is to be able to connect all of these data systems in a way that you're able to get data in a timely and a qualitative manner. And then the other point is about investing both in foundations and frontier. We speak about a lot of these innovations and interoperability and new techniques, but also not to forget that somebody spoke about surveys and lag in collection of data, household surveys, which are still important. There's been some improvements by using mobile-based phone surveys, but nevertheless, I think it's important to focus on foundations, whether it's surveys or the digital infrastructure, but also not forget the frontiers where you need to think about regulation. How do you bring together all of the stakeholders to collaborate on this? And then the last point I want to make is not to forget, again, the evidence of what works. Some of the new innovations that we're talking about are still in the early stages of implementation. So it's really important to document this evidence of what works and what doesn't, especially if you want to keep up with this, the pace at which these innovations are happening, while also respecting each country's digital maturity, because it's not a one-size-fits-all approach. You can learn from each other, but we have to respect what the journey of each country in how the digital development is happening in that country.
Thank you. We all know the problems sometimes we have with phones when you get the first generation. Yeah. Okay, great. Thank you. So now we're going to go on to online Global Health Initiative. Did you have a comment or answer on that, Steve?
I sure do. Thank you very much. So I think I would suggest a sort of change in mindset is needed to help improve the collaboration. I think we need to be open. We need to be humble. We need to be honest, and we need to be critical. So we need to be open to working together. We need to be humble in knowing that not one specific project, person, country has all of the ideas, and we need to be open to sharing these ideas. We need to be critical and look at what we're doing and see if it still makes sense, and see if our plans still make sense, and be able to be nimble and adjust to support the changing needs in individual countries. And then, just as the last speaker said, we really need to share these experiences. And yes, we need to share what works. That's important. But we really also need to share what doesn't work and what some of the challenges are in all this work that we're doing, because that's what really makes or breaks some of these digital transformation efforts, not just the high level shiny objects, but really talking about what didn't work and being able to make sure that we can share that honestly and others can learn from those experiences. Thank you.
Thank you. Civil society?
Yeah, thank you. So I want to highlight actually two suggestions of how we can really improve collaboration between stakeholders, partners, and governments. So the first one is around being very intentional. So I think there's a lot to talk about this, but being very intentional about how we prioritize inclusive, multi-stakeholder mechanisms and approaches around these issues. So really bringing different stakeholders together. So Transform Health, working with a number of partners, convened the development of a set of equity and rights-based health data governance principles. I won't go into detail because I have it's part of a presentation this afternoon, but the process around that was a very inclusive, bottom-up, multi-stakeholder process that was very intentional, that convened 8 global and regional workshops to bring together different stakeholders around this, to bring together and build on the expertise and the experiences of the different partners and perspectives. A public consultation around it, a youth-specific consultation around it to hear what youth had to say on this issue. So examples like that of what we can do more, being very intentional and putting into practice when we talk about inclusive multi-stakeholder approaches. And the second area, again, is ensuring that diverse stakeholders, including civil society, are represented within governance structures so that they're part of these processes, from planning, implementation to monitoring, and really have a seat at the table. So we talked about where we're positioned on the table. Very often civil society isn't even sitting at the table. So being very intentional in ensuring, and not just in a tokenistic way, but ensuring really the meaningful engagement and participation and hearing from what civil society and communities have to say around these issues. They're part of the discussions. Ultimately, they're the ultimate stakeholders. Their data we're talking about, they need to be part of how that's governed and how it's collected. and to ensure that that these systems are very responsive to their needs, including the most marginalized communities, youth, and which will also then help foster that trust in these systems, health information systems, the governance of those systems, and finally to ensure that those systems also are the accountability around them.
Thank you. And now to the private sector.
Private sector, improve collaboration. I think it's becoming a multi-million-dollar question on how to improve collaboration, right? I'm sorry to say, maybe we need a pandemic every 5 years for everybody to collaborate together, because we collaborated when COVID hit, and we saw the results of that. So it's a very dark side of it, but I think just building on what Kirsten said, it's about how many people like soccer here? Football, soccer, right? Mostly, yeah, me too. So in soccer, there is a clear goal that we need to hit the ball in the goal, and the team works together. There is a striker, there is a defender, there's a goalie, there's a team plan, right? We need a goal. That's exactly a strategy. And we all need to work around it and come together to implement it. And that has to be led by the government under the leadership of the ministries of health, private sector, NGOs, civil societies, everybody needs to come together, that umbrella, and implement that. I think second point, learning, of course, yeah, there's a lot of progress, but we also there are a lot of failures and challenges as well. So we need to learn from that and make sure how we can improve going forward. And that again, I think the third aspect is related to that is more, it's more shared accountability, right? Not just you have to do this, but we are in this together. What have you achieved and what I have achieved, and where are the challenges? So really having those mechanisms for shared accountability, where we can freely discuss the challenges and solutions to overcome them, and then go out and actually implement them. So yeah, I think improved collaboration is definitely a million-dollar question. And we have, Alain showed the slides earlier in terms of the pilotitis that happened, and we have come a long way from that. And there are now definitely guidelines and strategies that are available. But we need to have the goal in mind and strike the ball. Thank you.
Okay, so just to remind everyone, as we know, the goal is to put patients first and country needs first. But very good. So the word now goes to research academia.
Thank you. I don't want to repeat what's already been said. That, you know, collaboration is harder than it looks, even if though everybody agrees with it. One area of collaboration I just want to highlight, it came up a bit this morning, but I think collaboration across governments is critical. But like data is agnostic, data infrastructure is agnostic. Doesn't really care whether it's health data or economic data. So, you know, we need to think about how to leverage the progress that's being made in the ICT, but also in the private sector. How can we use that to better improve what health is needing and doing, and not replicating it, because you don't need to separately build out infrastructure for health if it's already available. And then to Vicas's point, the private sector is in many ways ahead. And so how do we actually take advantage of that rather than seeing that as a threat, which I think sometimes happens. But I guess I also want to point out that the shared vision of what we are trying to accomplish by digitalization and digital transformation is really fairly critical. And I want to, you know, take to heart the reporting burden. On the other hand, if you don't measure your progress, then you don't know whether you're making it. And I also would posit that the measures for digital aren't necessarily different than the measures for health. Ultimately, we want to see improvements in patient outcomes, but we also want to see improvements in availability of data. timeliness of data, data quality. How do we translate that to the technologists so that investments that we make in integration actually do translate into better sharing of data? Investments that we made in standardization actually make for more accurate and more timely data availability. So that shared vision is something that I think we need to continually work on, but that measuring it consistently actually will help to the shared vision.
Great, thank you. So now I'm going to stand up so I can see all of you fabulous people. Have we got any countries or comments, especially from the countries, on what they see here as the country partner collaboration? Come on, folks. South Sudan, we had 3 of you before, or 2 of you. Anyone else? Yes, please. Nepal, go ahead. Can we just pass one of these mics? Sorry. Thank you. And anyone else? Great. Sudan, Cameroon. Excellent. Okay, go ahead.
Yeah, thank you very much. Basically, in Nepal, we have development partners led by chair, WHO rotates or co-chair. So they discuss every fortnightly on different health issues, where data collaboration has been one of the big agenda because we had a very big mission in January where we had the presentation by Marina. And then here, actually, we try to collaborate because we see that different UN agencies, bilaterals, they are having different applications in different systems. So it's some, and also government is also taking up directly many of the partners, etc. NGOs, INGOs. So we we always have a very good discussion how we can collaborate with the partners. For example, MPDSR. This is one of the main area where WHO is working to have the responses to see how the responses are being made at the local levels based on the cause of death, maternal and perinatal. UNFP is also working on that, but we had an understanding. The collaboration is such that we do not do the duplication of efforts, and also see that GIZ is also working in some of the CRVS and other areas where WHO do not collaborate, but we provide the technical assistance. So however, due to the platform of development partners, we have a big role to resolve any of the issues, health issues related, supporting the government, particularly also the data which we were discussing upon. The main problem is that the investment. So we have to have a good investment in the country. Government has to have good financial allocations for HIS, otherwise it will not work. And partnership is also to be improved, but it is very difficult. The stakeholders have the different agenda, donors have the different agenda. So it becomes a very complicated. At the end of the day, we cannot manage, WHO cannot do it, and it's the role of the government. Thank you very much.
Okay, great. So now we're going to move on to a comment from the back of the room. Sorry, can you just give that to Sudan, please? Sorry, we've got a slight shortage of mic. Oh, he has it. Great. Go ahead, Sudan.
You mean South Sudan? You mean South Sudan?
South Sudan, sorry, South Sudan. Terrible. Okay, South Sudan. Fragile state. Thank you, South Sudan.
Thank you. And I would like to appreciate the panelists. And I'm happy to see some of the panelists representing institutions that are already in my country. I actually want to raise a concern as we speak of opportunities to partner and invest for better data governance and health information system. We do know issues of governance are normally sensitive. And as we also talk of how we can better improve the collaboration, I would like to bring to the attention of the panelists, as we very much remember, COVID has brought some of the innovations. We need to recognize COVID has successfully disorganized the world to some extent. Saying this because in my country, we have recently started to observe an influx of the private sector and their involvement, not only in the data, third-party monitoring mechanisms, and reporting, forgetting two aspects. Even if you want to improve the collaboration, how would that be done without effective engagement and conversations with the countries, and I mean the government? Because what we are seeing, there has been a kind of a networking, even at Geneva level or even at any other level, between the private sector, the multilaterals, the bilateral organizations, and around the resources. Now comes a situation where we, through such engagements, countries receive private sector entities engage to provide this service and that service without any effective engagement and discussions with the governments or the ministries of health. I'm happy to raise this concern simply because how would it be called investment when we know some of the private sector do not have any commitment to build the national capacities? And to my understanding, it wouldn't be an investment if it doesn't build a national capacity, if it also creates more dependency. The last is the aspect of efficiency. We know the cost of business in Geneva or in Nepal might not be the same cost in South Sudan. What you could be doing better in Nepal, you might not be successfully doing it in South Sudan. But what we are seeing is more of a generic approach, one size fits all, and all of a sudden you get a communication through the multilateral or the global health initiative mechanisms that are there that we have so and so, is to do 1, 2, 3 and provide these services. Thank you.
Thank you for that comment. And we have, I think, sorry, was there Pakistan?
This is Cameroon.
Yeah, Cameroon and Pakistan. And then we'll take the answers here. So please keep track of the questions, folks. Thanks. Cameroon, go ahead.
Thank you. I want to acknowledge the excellent presentations by the partners. I am Fanuel Habimana, and I'm the WHO representative in Cameroon. So when I speak, you realize that sometimes I put myself as if I am a member of the Ministry of Health, because I am privileged to be with the Secretary General of the Ministry of Health and also the technical advisor to the minister. In terms of partnership, we are very fortunate in Cameroon. We have a very strong partnership around this area, and I want to particularly acknowledge the support from GIZ. GIZ is a champion in strengthening the health system of Cameroon. Of course, we have also CDC, we have other partners. And during this meeting, I have learned with a lot of pleasure and interest, the interest of the World Bank in really supporting member states in moving forward in this area. So I was very pleased to meet the manager of data for the World Bank, and we are going to connect with the office of the World Bank in Cameroon to see how this area.
Thank you. Sorry, can we get to the question? Sorry, because we've got others. Thank you.
I don't have a question really. It's just appreciating that this is an important area, and for Cameroon, the issue of partnership I've already addressed. What I think is important for a country like Cameroon, we see that this meeting is an eye-opener, and member states are at different levels. I think we need to find out, what is the strength and the system, and see what is the journey to really reach what was described this morning, from the fragmented system, as we saw on the map of Uganda, towards the ideal situation, where the data, digital technology, and innovation are really at use to provide quality health systems. as of this group of people, vision, joint vision of partners to come to agree and do an assessment of our system. Because the country has just launched the universal recovery Asma, and we need a robust system to support this development.
Thank you, Pakistan. And then we're going to come to the panel.
Thank you. Thank you very much. Oh,
Sorry.
okay. That's government of Pakistan. I'm WHO.
Oh, sorry.
I give
Okay,
the floor
sorry.
to government.
So we'll let the country go first. Thank you.
Excuse me. Would somebody like to comment with me?
No, go ahead, Pakistan. Stand up, please. And your comment. Thank you.
It is
Question.
not a question, it's just a comment that I am seeing over the last so many years that government of Pakistan is investing into data collection system. Except UNICEF, we have not seen a lot of support by the respected panelists and other donors sitting online, or colleagues here in this hall. UNICEF is providing some support in logistics, in training component for maintaining the district health management system. Otherwise, since 1992, we are struggling to establish this system with the support of government of Pakistan. And government of Pakistan is only getting this data from the public sector hospitals. We don't have any data coming from private. And one of my colleagues highlighted.
Mic working. Okay, they can't hear you online. They can't hear you online. No, because you need the mic for online. Thanks.
My comment is over. I just wondering that we don't have any external support except when we talk about the vertical programs, for example, AIDS, TB, and malaria being supported by Global Fund, they support their MIS system, but that support will be available only till these grants are coming to Pakistan. For example, Gavi is supporting polio immunization. They have good system, MIS system in Pakistan, but that is only up to the availability of the funds being provided by the partners. Thank you.
Thank you. Did we want WHO comment?
Yes.
Brief and concise. Thank you.
Thank you. I try to be brief. So I represent basically WHO Pakistan. I'm head of the health system development. And what I want to say here is that we are talking about the health system, which is one of the blocks of the health system, data, which is one of the blocks of the health system. So we have to put whatever we are talking here in the context of that health systems. I think that is something that we have to all have in mind. And the second thing I want to mention is related to that. And we are talking about the data collaboratives, and we have collaboratives around health SDG 3, particularly gap collaboration. We talks about aligning, accelerating, and accounting together with the partners. And as an example, in Pakistan, we have a big, area of collaboration with many of the agencies around here, around that. So that has to be kept in mind, and WHO is really leading on that. And from headquarter level also, we are leading on that. So these two should be related to each other. So the question to the panelists would be how they are seeing that, how this data collaborative would be seen in the context of the whole health system and on the gap collaboration, in particular SDG 3 gap.
Thank you very much. Now to the panelists. So you've got your comments of all these different questions and comments to respond to. GIZ, you've also been mentioned personally.
Yeah, thank you very much also for highlighting our good collaboration in Cameroon. I know that we've been there for a long time, and our program there in health is really establishing good networks also in digital health. And I think we can move forward with this. And I think also we talk with some colleagues to have some activities also from our end. I just wanted to also respond also to the delegate of South Sudan, because I think he mentioned something very important here. We shouldn't forget really what the countries have in mind and also need to have to really strengthen their health systems. And I think the case that you highlighted, that everything is really sorted out or really decided in the global north and coming to your country and really giving you something that you maybe don't need and cannot really apply. And this is something also that we talk with my colleagues a lot within our office. And in that sense, we also established some collaboration with the Helena network and the Health Information Network in Africa to really emphasize and really enhance the capacities of health informatics systems also within the African region. And of course, I think this is something that should be continued and also enhanced, because this helps your country as well as other countries in the region to have the capacity that's needed and define the priorities and that they need. Because this case that you mentioned, I think it's something really outdated to come to a country and have a generic approach to something that wasn't really discussed with you. And I think we really need to be in a dialogue with countries. And I mean, GIZ is working in several countries. We have the mentioning of Cameroon, the example. In Nepal, we're also working very closely with the government. Also in regard to we have the interoperability lab, for example, to really overcome this fragmentation of data systems. And I think these approaches can be replicated in different contexts, but of course we have to be in dialogue with the governments and really establish that and respect also the needs of other countries and their governance. Because I sit in the headquarters, we talk about like a lot what can be needed, and I think sometimes we talk about it really in a meta level, and I think it's really important to have forums like this so we can discuss it and really get it from you what you need and what the critique is. Thank you.
Thank you. And in fact, that brings up a comment online, which reflects what South Sudan and others were saying, that they're asking who takes the initiative on these things. Is it the private sector, the NGOs, or is it the government? So this is also the experience on the ground, that there is a disconnect. Okay, we're going to move now to the multilaterals.
I think you really covered in a stow the points that you spoke about, how this, I mean, it's not again about a technology tool. Something that works in one place doesn't necessarily work in other places. I think we've already seen that with X-Road, which works really well for Estonia. People trying to adopt that in other countries just without considering the broader health system and architecture, or what is the necessary outcome, like the fit for purpose of why you would bring interoperability or why a certain technology tool would be embedded. We're seeing it doesn't work in some of the other countries. So definitely point well taken. And it's something that I guess everybody needs to work together to make sure that the government is involved, and it's per the priority of the government that is thinking about the broader strategy around why you're doing a certain implementation that's fit for a particular health outcome. So I don't want to repeat everything he said, and I just wanted to also acknowledge the points from Cameroon and Pakistan. I don't think, maybe I'll just respond to the comment online as to who takes the initiative. Government definitely needs to have a really big role in this. They have to bring together the stakeholders, decide the priority setting, and bring together the agenda. Maybe the initiative can be taken by an NGO, depending on the context, but still the government needs to be involved. They cannot be out of the equation in terms of how they bring the different stakeholders together. Thank you.
Great, thank you. Now we're going to go online to global health initiatives. Are you there, Steve?
I sure am, thank you. Yeah, I'd really like to, again, commend the speaker from South Sudan for raising these points. Again, back to the spirit of honesty and the spirit about what does not work. I mean, we heard things there. We heard solutions coming in without government involvement. We heard solutions, technologies being introduced without some aspect of capacity enhancement dealing with the health workforce and human resources. And we heard generic solutions coming in without contextualization. So let's just call that out as that is bad. that was wrong and needs to be addressed. So to some of these points, and I'll touch base on what Vikas said earlier about some of the collaboration that came in around the pandemic. It's true, there was a
Okay, it was frozen.
And there were also some challenges in using those tools, and they also needed to be adapted to different contexts. So again, there's a lot of great collaboration that can be done, but that importance of government involvement and contextualizing whatever solutions are there to make sure it's appropriate and responsive to the health system's needs are critical. Thank you.
Thank you. Now we're going to go to civil society.
Yeah, thank you. Yeah, apologies for being repetitive because I think very similar. I think we've all really heard really loudly what was said by colleagues from South Sudan. And so not to be repetitive of what you've already both said, but I think it just really emphasizes the importance of countries being in the lead and really driving these agendas and the role that partners can play in really helping to support countries then and aligning to countries' strategies and vision. But it also, I think, also really brings up the need and the urgency for that stronger enabling environment, the legislative regulatory environment, which essentially would then govern all of those actors operating in that country. So all of the data collectors and users, whether it's private sector, donors, civil society, by having that strong regulatory environment that governs the collection and use of data across all actors. So I think it really just also emphasizes that point. And the final point maybe just to make as well, I think convenings like we're having now are really important for highlighting a lot of these issues and challenges and needs and what we need to make progress. But I think what's really important to keep in mind also as we continue for the rest of the day and tomorrow is how we take those conversations and take them forward into concrete actions to drive progress and impact. So it doesn't sit with some nice conversations and initiatives and ideas, but we're really then taking those to drive action. So hopefully we can ensure that happens over the next day and a half.
Thank you. Private sector.
Thank you. I guess, again, not being repetitive, but maybe just to emphasize and also highlight an example and also seeing it firsthand from Ethiopia, where there was a few years back, there were multiple systems in place and data was all over. And then the government stepped up and brought the partners together. And as a country, they decided on one platform and the entire country, all the provinces were moved on that DHIS2 platform to have a common sort of an architecture. So, again, the shared accountability aspect is really key and the goal. Let's identify our goal and let's hit the ball. Thank you.
Thank you. Research, academia.
Thank you. The one point that I will just reemphasize I thought was important is the movement away from reliance on donors to make decisions about digital. That the country, the goal of many of the work that we're providing technical input on is how does one improve, how does help mature the governance structures as well, and the financial, the costing of models so people understand what it takes to digitize. All of those decisions have to be made by the country governments, and then the role of the technical partners is, I think, to empower and to inform how to make a good decision. But decisions made and imposed from outside are not going to be successful, and then we need to, underscore that point. It's been made several times.
Thank you. So before we clap the panel, sorry, I'm just going to stand up so you can see me well. Right, we're breaking for lunch. And what we need to do, they will not serve anyone. You cannot get any food until everybody is seated. So after we give a massive round of applause to this fabulous panel, please, can you go downstairs? You go out you go immediately right and then right. Okay, so it's kind of on the parallel door from where you go out on the right. And go in then, please sit down, and then we can have lunch. So please, thank you. Let's all applaud. Thank you, well done.